और एक है डॉक्टर जयराम, 3 आए हैं।
इनके तो नाम ही नहीं है इस लिस्ट में।
हाँ, इनमें तो है ही, इनके नाम ही नहीं है।
हाँ, तो ये क्या बोल रहे हैं?
नहीं, वो है ना, एक मिनट, एक है ना डॉक्टर किशन पटेल इज देयर, डॉक्टर जय
5510।
किशन
बॉस,
पटेल
उनका
इज
नाम
देयर।
नहीं है, तीनों का नाम नहीं है इस लिस्ट में।
नहीं, किशन पटेल तो है ना
यार ये लिस्ट मेरे सामने है, इसमें कहाँ नाम है?
नहीं, जो फ्लायर में तो है ना।
Just sharing the screen, sir.
यू इनवाइट डॉक्टर किशन पटेल, इनको सबको कर लो इनवाइट।
Right, sir.
Actually, Ayush Bhargava is on the second session.
Good afternoon, sir. We are live now.
आयुष भार्गव का है इसमें नाम?
This Manish, sir.
Yes, sir.
Yeah, we are live now, sir.
Yeah, good afternoon, everyone, and I'm very delighted to invite you all for this DOACON special session on the free papers. And this program is sponsored by IPCA Lab, makers of Zero Doll. And I now request Dr. Sikand Sinha and Dr. Barjinder Singh, who are the chairpersons of this session, to take over the proceedings and start the free paper session. There is a short video of the sponsor, so just after this we will start.
Thank you, sir. We'll start now, sir.
Dr. Sinha and Dr. Barjinder, please take over.
Good evening. I am Dr. Sinha. I request Dr. Barjinder to call speakers from his list.
Yeah, good evening, everybody. This is Dr. Barjinder Singh.
Yes,
and thanks, Dr. Manish, Dr. Shamshul, and other respected faculty and the speakers. Today we are having the DOACON 2020 online. We are in Hall B. This is a free paper session. So there are 11 speakers in the list for this. Let's see how many have joined so that we can start. Dr. Prateek Mandal, is he there? I think if I can see the list, I could find Dr. Ayush Bhargav there. Dr. Ayush, are you ready with the presentation? We can skip the sequence. So may I request Dr. Ayush to start with this free paper till the time the others will join so that we can reshuffle the sequence.
Well, uncle ne gaadi aa gayi.
All others are requested to kindly keep their microphones on mute. Dr. Ayush, you can share the screen and start.
Okay. So is it visible?
Screen is visible, but the presentation is not visible.
Please start your presentation.
I've started my presentation. I can see the first slide.
We can't see the first slide.
Just open your presentation first, then share the presentation directly.
Okay, sir. Okay, sir.
Yeah. Stop screen sharing. Yeah. In the background, please start your presentation.
Hi, Shamshul.
Hello. Ashok bhai, how are you?
I'm fine. Yeah. How are you doing?
Very good.
So we are starting at 4:15, right?
Right.
Yeah. So in the other room also, we'll start at 4:15.
Sir, is the presentation visible?
Yeah, it's visible.
Can I start now, sir?
Please start.
Okay, sir. Good afternoon, all the seniors. I'm here to present my paper on analysis of treatment outcome in TB spine, sir. As we all know, the duration of chemotherapy in TB spine is an unresolved issue. Various drug regime have been used for various duration. Initially, for extrapulmonary tuberculosis, 18-month chemotherapy was advised, but it was associated with high drug-related toxicity and poor patient compliance. Then a short course was introduced, which was associated with recurrences and non-healing of tubercular lesions. So our study was conducted with an objective to calculate the duration of ATT required for achieving a healed status of in TB spine, to report the behavior of kyphotic deformity during the treatment, and to report the outcome of neurological deficit. It was a longitudinal study. 76 cases of confirmed cases of TB spine were taken. They were either diagnosed radiographically or on the basis of histopath or on CBNAT or LPA. They were treated as per the RNTCP guidelines by a single author, and surgery was reserved for well-defined indications like paraplegia, deterioration of neurological deficit, no response to conservative treatment, and others. The ETT was only stopped after the healed status was demonstrated either on a contrast enhanced MRI or on a PET scan. These patients were then follow up every monthly for clinical evaluation, ESR, X-ray. Kyphotic deformity and neurological status were noted at every visit. These patients were then categorized on the basis of duration of ATT taken into either a 12-month group, 15 to 18-month group, or more than 18 months of ATT intake group. Those patients who were not under whose previous treatment records were not available, nor the patient whose diagnosis or treatment were not under by our protocol, were excluded from the study. This is a case of a pot spine D4, D6 with grade 4 paraplegia, whose radiographic images at presentation are shown above. Patient was then started on ATT, anterolateral decompression with resection, and a heart cell fixation was done. Patient was then followed up. Patient had an MRI done at 12 months, then at 18 months, then at 24 months. At 24 months, the patient contrast enhanced MRI and PET both showed resolution of the lesion, and the ATT was stopped. Our observation in the study were, out of the 76 patients, 35, that is 46% were diagnosed on radiographically, while the other 53% on molecular or histopath. The dorsal spine was the most common segment involved in 40% of the cases. Neural deficit was absent in 65%, whereas it was present in 34% of the cases. Out of the 76 cases, 49 cases were treated conservatively, while other 27 required additional surgical intervention. ATT was stopped in 72% of the cases on the basis of healing signs in MRI, whereas in other 28%, it was on PET CT, as the patient had some metallic implant in which MRI was not possible. Here's a chart of patient duration. In 26 patients, ATT was stopped at 12 months. In another 16 by 18 months, in another 11 by 24 months, and in another 13, the duration exceeded more than 24 months. There were 10 drug resistance cases in which ATT was given for a minimum of 24 months. The results of our study was the mean duration of healing achieved in the cases were around 20 months, and there was no recurrences seen in any of the case after a mean follow-up of 15 months. 96% of the cases showed a good neurological outcome at the final follow-up. The mean kyphotic deformity in both conservative as well as operative at presentation was around 16 degrees, at completion of treatment was 18 degrees, and at final follow-up was 18.78 degrees. We finally concluded from our study that a graded duration of ATD should be given till the healing is achieved on contrast enhanced MRI or PET CT. So the number of cases in our study was less, but there was no recurrences in any of the cases. That's why we would say this for graded duration of ATD should be given in port spines. Thanks.
Thank you, Dr. Ayush Bhargav. It was a nice presentation.
Thank you, sir.
And you stick to the time. That's very nice. So if the other panelists are there, if they have any questions, they can ask Dr. Vikas Gupta and Dr. Sanjay Tripathi. May I ask you a question?
Yes, sir.
What is the criteria of stopping the ATD?
So only after getting a heel status and on a contrast enhanced MRI or PET CT, sir. In a PET CT, if we get an SUV of less than 3.5, or in contrast enhanced MRI, if there is no collection at the last MRI, sir.
Okay. Dr. Sakand, you have any question?
How many drugs do you give for this long period?
So we followed the RNTCP guidelines initially. Initially, we started with HRZE. Then in the continuation phase, we continued with HRE and E.
And do you rely on blood investigations or purely on imaging?
So patient was followed at every visit. So ESR was done. So we relied on ESR for some.
So are there any cases where blood investigations were normal and imaging was showing non-resolution of lesion?
Yes, sir. In few cases, there was collection in contrast enhanced MRI and ESR was normal. Some of these patients were subjected to PET CT, sir, in which the SUV uptake in those lesions were less than 3.5. We considered them as sterile abscess and we stopped the treatment, sir.
Okay.
You can stop sharing the screen now.
Okay.
Any other question? If somebody wants to ask. I think thank you, Dr. Bhargav. That was a nice presentation.
Thank you.
I think all the speakers have not joined, so we have to start with the ones who have joined. And I can see is Dr. Jay Karan. Can you hear me?
Yes, sir. Good afternoon.
Good afternoon. Your presentation is ready?
Yes, sir.
Okay. So Dr. Jay Karan will start on free paper on the comparative evaluation of 3 different techniques of inserting a Steinman pin. You can start sharing the screen and go ahead with the presentation.
Okay, sir. I'm visible, sir?
Yes.
Good afternoon to all of you. Today I am presenting my topic of comparative evaluation of 3 different techniques of inserting Steinman pin for applying a skull traction, which is done under the guidance of Ajay Kumar Gupta, sir. Introduction. Skeleton traction is one of the most commonly used procedure in the orthopedics practice, which is used for reducing dislocation, aligning fractures, correcting the deformities. As we know that the application of skeleton traction is done through a hammering either drilling through the bone. As we know that the clinical complications of the procedure include pin track infections, pin loosening, and local bone combination, CPN palsy, arterial injury, etc. As we know that the factor affecting the prevalence of such complications include insertion technique like hammering, hand drill, or power drilling. Or second is pin tip design. The effect of insertion of different pins and drill on the bone pin interface has been studied in the term of mechanical damage, thermal necrosis, or inflammation of bone around the pin. So these structure alteration has not been translated into the various clinical manifestation, but have not studied till now. So in our study, we propose the study the insertion of pin through the bone using three techniques and compare their safety profiles and various complications. So we have taken a three group. Group A is the hammering the steaming pin with diamond tip, and group B is drilling the steaming pin with diamond tip using hand drill, and third group is drilling the pin with spiral fluted tip using hand drill, that is group C. In figure we have seen that right side is spiral fluted tip and the other left side is diamond tip. Aim is to assess and compare the pin track related complication among three commonly employed techniques and investigate the best insertion technique for applying skeleton traction. Our material and method study design was prospective comparative study, and place of study was Department of Orthopedics in MAMC, and sample size was 60 patients. Inclusion criteria were age more than 80 to 50 years with lower limb trauma requiring upper and lower tibial or distal femoral pin, or lower limb deformities requiring upper lower tibial and distal femoral pin. Exclusion criteria were open injury of the same bone, then the patients, if patient is having an immunodeficiency like diabetes mellitus, HIV, CKD, chronic anemia, long-standing malignancy. The other one is unhealthy local skin condition around the skin, around where the skin, pin has to be drilled. And the other is fracture in the close vicinity of the pins insertion. These are the figures we have inserted 2 centimeter below the tibial tuberosity and lateral to the tibial tuberosity for UTSP, and for LTSP we have taken 5 centimeter above the tip of medial malleolus in the middle of anterior posterior tibial bone. Primary outcome which we have calculated is pain at local site using visual analog scale, pin track infection using more and dull pin site classification, pin loosening, bone combination at the pin site which is through X-ray, and any other complication reported during the study. So result was VAS score was maximum in group A, which was hammering the pin through the bone, and pin track infection was more on group B, which was hammering the diamond tip through a hand drill, and the pin loosening was maximum in group B, the same in which the pin track infection was more, and bone combination was maximum in group A, that was hammering. Another complication was included in group A only, which occurred when I was drilling the steaming pin. There was fracture in the lower tibia segment. These are the result change in the VAS score over the time. As we go from day 7, the patient has no complaint of pain, and pin track infection was more on group B, there was no pin track infection was seen in group C and group A, and pin loosening was maximum on group B and compared to A. So discussion, the pain at local site using Wasco. In our study, the pain at local site on day 1 was maximum in group A, that is hammering, and mean scoreage were decreased with time while patient in all the 3 were pain free on day 3. And this suggests hammering the steaming pin caused more structural damage to the bone, resulting in more pain. And the least painful technique was diamond tip steaming pin, that due to increased penetration efficiency. The pin track infection was in our study was 5% incidence and was maximum in group B, that was steaming pin with diamond tip using hand drill. As in our Matthews and Green study on a human bone found that temperature elevation persistent longer in the bone surrounding the hand drill inserted pin because of bone death and necrosis with the sign of inflammation and periosteal reaction leading to pin track infection. As we know that the maximum infection was on diamond tip due to there is no provision for elimination of hot chips and bony fragments, so that produce a very high maximum temperature over long duration of time due to relatively large area of cortical bone. In our study, we use the spiral fluted drill tip which displays material from the tip, while cutting edge of drill tip shears the material from the surface. And Pisaka study was similar, that he used a 2 spiral twisted drill which shows that low insertion force than the trocar and diamond tip. So pin loosening was in also study was 15%, but in our study 5% incidence of pin loosening. The maximum loosening was stimin pin insertion through hand drill, which is probably due to increased rate of pin track infection due to increased thermal necrosis. Bone combination was more on hammering the stimin pin with diamond trip, and microfracture which was reported that was disappear in 4 weeks. So we encountered a fracture during hammering the pin or applying lower tibial cement pin traction, but that may be possibly due to ironous insertion of pin toward more diaphyseal area. Take home message is hammering the stimin pin with diamond tip was found to be the better than drilling, but due to bone combination and complication, we avoid hammering. So drilling the tip pin with spiral fluted drill bit has the least pin track related complication compared to drilling with diamond tip or hammering, and was found to be best. Thank you.
Thank you, Karan, Dr. Karan, for a nice
Yes,
presentation. Now paper is open for discussion.
yes, sir.
May I ask Dr. Sakan Sinha if he has any queries or questions for Dr. Karan?
Yes, sir.
No.
Okay. So which method do you recommend for inserting the Steinman pins to everybody? Just a recap.
Yes, sir. I will suggest if we use a spiral fluted tip pin as compared to the diamond tip, so we can use a hand drill through a spiral fluted tip. We have designed that. Avoid using diamond tip or hammering which the historical we shows that hammering the pin which give a good result on pin track infection and all that. But if we modify the pin tips design, so that can be easily, we can reduce the infection rate and complication during. We know that in this pandemic area where we can't do a surgery so often, so that if patient is coming with corona and we want to give a conservative management for and delaying surgery, so we can put these pins through that, so we can improve better.
Have you noticed any changes with the diameter of the Steinman pin also?
No, sir. No, sir. That was similar. We have used the same diameter of diamond tip, but we have 4.5 we have used for 3, but we have changed the tip. Because of that tip, the bone which was inside, the chip was taken out from the bone, so there was low heat production around the pin.
Okay.
Dr. Brajinder, can I ask a question?
Yeah, sure.
So, Dr. Sir, very nice presentation. Was there any age difference in your infection rate?
Yes, sir.
Did you had a certain number of infections, as you said, in the pin tracks?
Yes,
did,
sir.
Did you see any age gap difference in the infection rate of your pins?
No, sir. No, sir.
So all young patients got pins and all young patients got infected?
No, sir. We have taken 18 to 30 centimeter, 18 to 60 patient, 18 to 60 years. So
in the
infection was
group,
means three patients having an infection. One was 30 years and one was 55 and other was on 40. So there was no means we can't
no
signify
such
that
question.
age
Thank you.
factor.
Thank you.
Hello.
That was a nice presentation. Thank you, Doctor.
Thank you, sir.
May I request everybody to please write down your names in the Zoom ID, because it's difficult to identify which are present and which are not present. Somewhere it's written Redmi and iPhone and like that. So if you can mention your name, it's easy for me to identify who are present. Next I could see is Dr. Shashank Verma. Are you ready with your presentation? Dr. Shashank Verma.
Yes, sir, I'm ready.
Okay. He will be presenting on clinical radiological outcome of arthroscopic all inside ACL reconstruction. I think you can start your presentation, Doctor. Start the screen sharing, please.
Yes, sir.
Others, please write down your names so that we can identify who are present.
So is my screen visible?
Yes, yes. Go ahead.
Just to see. So is this visible?
Yeah, it's visible. Continue.
Respected mentors, my seniors, and my dear colleagues, a very good evening to you. Today I have got the opportunity to present before you an innovative approach of modified trialing technique of arthroscopic all-inside anterior cruciate ligament reconstruction using autogenous semitendinosus graft under the guidance of Dr. Vinod Kumar sir. The surgical technique of arthroscopic ACL reconstruction continues to evolve, and it has evolved from the conventional gold standard single bundle ACL reconstruction to anatomic double bundle ACL reconstruction. Also, we have adapted from creating bony tunnels to small bony sockets, which are much more bone preserving. The standard trailing technique makes use of a graft configured in a shape of Y, which increases its rotation, the rotation stability of the technique. Also, it maximizes the stability by recreating the anatomic function and isometry of the two bundles of the ACL. But it had certain limitations, which were due to the inability to not orient properly the anteromedial and posterolateral bundles anatomically. Since the graft was configured outside and the differential tension required to produce was not able to be carried out intraoperatively. To tackle these issues, a novel technique of all-inside double bundle ACL reconstruction by single tibial socket and two femoral sockets, that is our modified trailing technique, was innovated, which tackles the tunnels confluence related issues like loosening of the graft. Also, it gives better orientation since graft are passed one by one, and it gave the required differential tension in both the bundles. Our technique was an interventional prospective clinical study which recruited 18 patients which were followed up for a period of 6 months post-operatively, and it included clinical radiologically diagnosed symptomatic cases of complete ACL tear with unstable knee in the age group of 18 to 60 years. And the patients who were having pre-existing degenerative changes in the knee or any ligament injuries requiring operative repair, or patients with history of previous knee surgeries or with ACL avulsion bony fractures were excluded from the study. Proper history and clinical examination using Lashman's test, anterior test, and pivot shift test was done with the help of investigations such as X-rays and MRI. Also, clinically the scores were documented such as IKDC score, lysome scoring, co-score, and Tegner score. Also, we incorporated KT1000 study for testing anterior laxity. Now I'm going to show you the surgical technique with the help of a small video, in which first after placing the patient in supine position and under anesthesia, that arthroscopic portals were made, diagnostic scopy was done, any associated meniscal injuries were identified, the diagnosis was confirmed of torn ACL, which was then removed in which the debris were removed by a shaver. The graft was harvested from ipsilateral semitendinosus and was prepared in two separate bundles, which was different from the standard trialing technique in which the graft was configured outside in the shape of Y. Then the femoral footprint of the ACL was prepared using radiofrequency ablation probe, and the anteromedial and posterolateral sockets were drilled. The sockets were measured and was marked on the graft preoperatively. Then we create, by the same technique, we create a tibial socket with the use of a jig at 55-degree angle, making with the use of retrocutter to create bony sockets instead of tunnels. By unflipping the retrocutter, we then take it out. Then we pass loop wires to the tunnels, and then we shunt them outside through a portal made in the knee. After being shunted, we then place the grafts on the through the shuttles and then milk them through the tunnels created. And then we flip the endocrine. This is the most crucial step in the technique since AM bundle is passed anterior to the pair bundle, orienting them in the proper native anatomical position. Then by the same technique, AM bundle is also milked through a tunnel, the endo button is flipped, and then the graft are passed through the T-bell tunnels. Then it is fixed using endo button. Then final tensioning of the graft is done. The PL bundle is tightened in extension, whereas the AM bundle is tightened in 90-degree flexion, which gives the required differential tension. The final picture of the graft is like this, and then we check for notch impingement. Then the post-op period. At 6 weeks and 3 months, we evaluate the patient in terms of the scoring, which was done preoperatively also. Then we measure the outcomes. Also, the clinical examination and KT1000 study are performed at 6 months along with X-rays, CT scan, and MRI. The outcomes are assessed in terms of the primary outcome is on the scoring of the patient, like IKDC score, Lysom score, diagnosis and score, and the CT and the MRI are taken as secondary outcomes. Now to conclude that the placement of two different stents in place of the Y graft provide the ability of differential tension over the two bundles, which was not possible in the standard trialing technique. Also, better orientation of the two bundles was possible using this technique, since it mimics natural knee kinematics and native knee anastomometry similar to the anatomic bundles. The early results of the technique are encouraging, but the final results are awaited. Thank you, sir.
Thank you, Dr. Shashank, for a nice presentation. The paper is open for discussion. Any questions? Dr. Sikand?
Dr. Shashank, can I ask you one question?
Yes, sir.
Dr. Shashank, when we see normal footprint of ACL,
yes,
the tibial footprint is twice as large as the femoral footprint, right?
Yes, sir.
So in making it reverse Y, you are increasing the femoral footprint and decreasing the tibial footprint. So how is it better than a standard double bundle?
Sir, the femoral footprint is enlarged is large than the tibial when we do it. Because of this, we create two sockets in the femur and one in the tibia.
You're not getting my question. I asked that tibial footprint in a normal knee is larger than the femoral footprint, right? But when you do this reverse Y or tri-link construct, the femoral footprint is more than the tibial footprint. Tibial footprint is a single circle.
Yes,
the surface area will be lesser than two small circles. So the tibial footprint is smaller than the femoral footprint. So how do you claim it to be better than a standard double bundle? In standard double bundle, tibial footprint is more.
Yes, sir. So the bone is in the double bundle. The bone is by creating two tunnels or two sockets, we take out more bone. But by preserving the bone and the structure around it, we have more knee flexion strength. That's why it's better.
Thank you.
Any other question from the other members present? No one? So we can move on to the next speaker now. Thank you, Dr. Shashank. Thanks for a nice presentation. From the list of attendees, I could see Dr. Rakesh Singh. Dr. Rakesh Singh, are you there? Kindly unmute yourself.
Yes, sir.
Yeah. Is your presentation ready?
Yes, sir, almost.
Okay, so Dr. Rakesh Singh will present on the clinical radiological outcomes of post-operative slight residual varus in total knee replacement for moderate to severe varus deformity. You can share your screen. Before that, may I request the other speakers who are ready, kindly send a message on the chat box because the names are not as per the list. So I might be missing somebody. You can start, Dr. Rakesh.
Okay. Good evening, everyone. Uh, my today topic of my paper is clinical radiological outcomes of post-operative slight residual varus axis in total knee replacement for moderate to severe varus deformity. So, knee osteoarthritis, it is a painful and disabling disease. It gradually restricts the range of motion and mobility. Osteoarthritis, also known as degenerative arthritis or degenerative joint disease or osteoarthritis, is a group of mechanical abnormalities involving degradation of joints, including articular cartilage and subchondral bone. The disease occurs when the dynamic equilibrium between the breakdown and the repair of joint tissues become unbalanced, often in a situation where the mechanical loads applied exceed those that can be tolerated by the joint tissue. Total knee arthroplasty. It is most of the one of the most performed surgeries for OA knee with increased life expectancies. Correct. Alignment of component in coronal, sagittal, and axial plane are desirable for optimum
नहीं
clinical
गौरी करेगा
outcome,
इसमें तो ये नहीं कर रहे
patient satisfaction,
सीधा
and
तेरे लॉक है ना
efficiency.
ठीक है तेरे को वहां पे भाई क्या
The
सिंटेक्स नहीं है
alignment of the
राइट
total
Please keep
body
your
total
mics on mute.
placement,
वो इसमें है
There's
वो
a
बोल रहा है सीधा
disturbance.
तुम चैट बॉक्स में लिख दो अपना सीधा
practical survival of the
एक बार लिस्ट
prosthesis.
देखना इसमें अपना
The
नाम
general consideration is that an overall
एंटर क्लिक
mechanical
कर रहा है
procedure
वो जिसका
alignment
वो बात नहीं
approach
कर
is the goal of surgery to reduce implant failure. The aim of study is to assess the clinical and functional outcomes of patients
Kindly
with
mute your
residual
mics, please.
varus femoral tibial axis. Research question. My research question: does a slight residual varus improve clinical radiological outcomes in a total knee replacement for moderate to severe varus deformity? And it's my aim and objective to evaluate clinical and radiological outcomes of post-operative slight residual varus TKR, total knee replacement for moderate to severe varus deformity. It's a prospective observational studies which is done at Department of Orthopedics, RML Hospital, New Delhi. And my inclusion criteria was patient with end stage, that is grade 3 and grade 4 of Calgary Lawrence classification of either sex, age 50 years or above, with moderate to severe varus deformity that is more than 10 degree. And exclusion criteria was uh, patient with inflammatory arthritis and with neurovascular disease and who had undergone prior osteotomy involving knee joint. Functional outcome will be done by using American Knee Society score at third month post-operatively, and patient follow-up done at 2 weeks and 3 months after the surgery. The measurement of femoral and tibial TK component placement in sagittal plane with respect to femoral and tibial anatomical axis respectively will be done by method of Knee Society score, TKA radiographic evaluation. On comparison of pre and after 3 month post-op AK American Knee Society score, there was uh, that score was significantly higher than pre-op. And if we are talking about visual analog score at second week and 3 month, it was there is significant reduction in was scored at second week post-operatively, and even at third month, 3 months of post-operatively. Um, Calgren and Lawrence were the first investigators to provide a classification where OA was divided into 5 grades. In this study, clinical radiological residual varus alteration in total knee replacement for moderate to severe varus deformity was studied. And patient follows were done at second week and 3 months after the surgery. Post-operatively, scanogram with marked anatomical axis of both femur and tibia were done at second week. The measurement of femoral and tibial TK component placement in sagittal plane with respect to femoral and tibial anatomical axis respectively was done by method of knee society TK radiological evaluation. Functional assessment was done using American Knee Society score at and was at 3 months. Thank you so much.
Thank you, Dr. Rakesh Singh, for a nice presentation. The paper is open for discussion now. You can stop the sharing.
Yes.
If there's any question from anybody. Questions?
Dr. Rakesh,
Yes, sir.
You have not categorized your results crystal clear for the listeners. How many cases were outliers?
Sir, it was 40 knee operated with 20 in right side and 20 in left side. Then,
so how many cases had residual varus?
Sir, everyone only I included more than 10 varus deformity in my studies. So every one in out of 40 have more than varus deformity more than 10 degrees.
I am talking about post-surgical residual varus.
Sir, up to 4 degree. Sir, post residual varus it's up to 4 degrees, sir. And my average of that virus is 2.1 in all 40 cases, sir.
So how this residual varus is better than a knee which is neutral or in slight valgus?
According to American Knee Society score and
no, according to your results. According to your results.
Sir, clinically, patient feel better. In my studies, after a follow-up at second week and 3 months of after surgery.
Thank you.
Thank you, sir.
Any other question from anybody? Okay. Thank you, Dr. Rakesh.
Thank you, sir. Thank you so much.
We move on to the next speaker now. Dr. Anubhav Vichitra is there. Kindly unmute yourself.
Yes, sir, I'm here.
Okay. Are you ready with the presentation?
Yes, sir.
Okay. Dr. Anubhav will be presenting to evaluate accuracy of bony alignment using computer-assisted hexapod fixator in correction of long bone deformities of lower limb. You can start your screen sharing now, doctor.
So is my screen visible?
Yes, it's visible. Go ahead.
Good morning to all. I'm Dr. Anubhav Vichitra from Maulana Azad Medical College, PG second year, orthopedics, and I'm going to present on my topic to evaluate the bony accuracy of bony alignment using computer-assisted hexapod fixator. Correct. Just a minute. To evaluate the accuracy of bony alignment using computer-assisted hexapod fixator in correction of long bone deformities of the lower limb. And conventionally, the correction maneuvers for multiplanar deformities require custom-made Elizarov frame for each deformity component. And this may be cumbersome, time-consuming, and even impossible sometimes. As you can see on the right side, there are various different deformity components, and each requires a different Elizarov frame assembly. But software-assisted hexapod fixator, like Taylor spatial frame, ortho SUV frame, proposes to solve this problem of repeated frame transformations and offers simultaneous correction of all the deformity components. And with good alignment and orientation. The aims and objectives of my study were to evaluate the radiographic accuracy of alignment in deformity correction using a computer-assisted hexapod fixator in long bone deformities of the lower limb, and to also evaluate the computer-assisted deformity correction maneuver and its execution. It was a prospective interventional study, and the duration was from October 2019 to November 2020. The place was Lok Naik Hospital, New Delhi, and the sample size was 10 patients. We included all clinical radiological diagnosed cases of lower limb deformities requiring treatment by the Elizarov method, and the age were between 18 to 60 years. In exclusion, we used Elizarov fixator treated lower limb deformity cases where acceptable bony alignment could be achieved intraoperatively. And if there were any injuries on the ipsilateral limb requiring vascular repairs, then they were excluded as well. Age more than 60 years and less than 18 years were excluded as well. Preoperative criteria, preoperative parameters, we used history and examination, x-rays in both AP and lateral views. Deformity quantification was done. The bone involved, the core of the deformity, reference lines and angles, rotational malalignment, limb-length discrepancy, and deformity type according to Manor et al. Post-operatively, the follow-up plan was individualized according to the clinical entity being treated. The deformity correction was assessed after the computer-prescribed correction maneuver, clinically and by the core of the deformity, the reference lines and angles, if any residual rotational malalignment was present, residual limb-length discrepancy, if any, and residual deformity type according to Manor et al. According to Manor et al., there were 4 deformity types: type 1, which is 1-dimensional; type 2, 2-dimensional; 3, 3-dimensional; and 4, 4-dimensional. In type 1, the cases with leg lengthening procedure was only required. That was in type 1, with no other deformities. In type 2, cases with leg lengthening procedure as well as any other deformity present in frontal, sagittal, or rotational plane. Similarly, in type 3, there were 3 components, and then in type 4, there were 4 of them. In the procedure, first the segmental measurements were done. Values on the opposite side were taken as, or the standard values were taken as normal values. Efficacy was assessed after the correction with decrease in grade of Manner's deformity type. Decrease in the deformity was graded as if there was complete resolution, then excellent. Type 1 residual deformity, if any present, then good. Type 2, 3, or 4 residual deformities present, then poor. On the right side, you can see the anatomical and mechanical axes and angles. In procedure, newer generation hexapod fixator was applied on pre-applied Elizarov ring fixator using the prescribed manual. In some patients, it was mounted intra-op, while in others in the follow-up period. This is the software, and this is how we, after measuring the strut lengths and the triangle basis, we enter all the values, and the SUV software plans accordingly and gives us the final chart of the correction maneuver, which is this. So after the planning was done using the accompanying ortho SUV software, the radiographically confirmed deformity correction was done according to the software prescribed maneuver. And finally, the hexapod was replaced by the threaded rods of the Elizarov frame to prevent any change in the position of the rings that was achieved during the correction. On the right side, you can see how we measure the strut lengths via measuring tape. And there's a X-ray on which we calculate all the angles and axes of the struts, and further calculations are done by the software. This is, as I told you, this is the final correction maneuver. We can plan it according to the days we need it, and the timing, whether we want it 4 times a day or 2 times a day. The observations and results we found out that accuracy of realignment maneuver was assessed by residual percentage of each component of the deformity, and if any while in the correction maneuver analysis, we saw the number of maneuvers needed, any hardware related problems and any clinical problems. All 10 deformities got reversed and realigned to an optimal level, and Manus grading was reversed to grade 1 or grade 0 in all patients. One patient required a subsequent correction maneuver as the deformity was not adequately corrected after the primary one. This is one of the examples of deformity in the proximal tibia. SUV was applied and correction was done, and final X-ray showed this after. And this is this is infected non-union femur X-rays, and finally the SUV was applied and correction was done, and the final X-ray showed like this. In discussion, I would like to say that the angulation, translation, rotation could be reversed to an excellent level on the patients, and axial length mismatch was corrected to excellent level or good level in all patients. In take-home message, I would like to say that the computer-assisted hexapod fixator has a really good precision in deformity correction with reproducible results, and software-assisted hexapod fixator solves the problem of the repeated frame transformations required by conventional Elizarov method and offers simultaneous correction of all deformities with good alignment and orientation. Interpersonal variations and human error of conventional method is eliminated. Inaccurate measurements are the only source of failed correction maneuver. Thank you.
Thank you, Dr. Anubhav Vichitra, for a nice presentation. The paper is open for discussion.
Yeah, Dr. Banjadan, can I ask a question? Am I allowed?
Yeah, sure. Yes, yes.
I just want to know to the presenter that how do you find, what is the difference you found between SUV and the Taylor special frame?
So in Taylor special frame, for each particular deformity, or for one, if we want to apply, we have to get a
No, I'm just asking you that you have applied SUV, you have applied Taylor special frame.
No, we didn't apply Taylor special frame. We applied only SUV.
Because in your lecture it was mentioned that Taylor special frame.
Yeah, I was giving an example of what other computer-assisted hexapods can be applied.
So, what do you think that what are the disadvantages of SUV? Means technically, what are the problems patient face with SUV? Can you elaborate on that?
Personally, one of the problems that the patient did face when in which one we applied this SUV in a proximal femur fracture, and in that particular case, the SUV was continuously impinging on the genital and groin area. And other problem with the hardware was that because of the sometimes after applying the struts of the SUV, while rotating the struts, sometimes it get jammed with the Elizarov ring. So that was one of the problems. More or less, these were the ones we faced usually.
Yeah, actually, SUV is more bulky because it is applied on the Elizarov frame.
Yes, sir.
So it is sometimes uncomfortable to patient because of its bulkiness.
Yes,
so Taylor's special frame is less bulky, but the level of correction in both the devices is almost the same. Maybe the this software is slightly easy in Taylor special frame than SUV, but SUV has a built-in software.
Yes, sir.
Taylor special frame is a net-based software.
Again, sir, we require every time we would require a different Taylor special frame for a particular person, and SUV can be applied on different on different kinds of rings. The same SUV can be applied on different sizes of rings.
What kind of rings you use with SUV?
So we use the regular Elizarov frame rings.
So does the rings have any consideration in the software?
What, sir?
Does the rings have any consideration in the software?
In the software per se?
See, actually, the SUV rings SUV is independent of rings. So any ring you can use.
Yes, that's what I'm saying. Taylor special frame requires a particular construct. We require a separate Taylor special frame for every
specific
kind of ring. Yeah.
Okay. Over to Dr. Barjinder now.
Yeah, thanks for a nice discussion and quite helpful for the listeners also. Any other question from anybody? If there's no question, we move on to the next speaker. Dr. Prateek Mandal, are you there?
Yes, sir, I'm there, sir.
Yeah, kindly unmute yourself. Keep the presentation
sir.
ready.
Yes, sir.
Dr. Prateek will be speaking on spectrum and magnitude of congenital limb deficiencies in children less than 18 years.
Yes, sir.
Yeah, kindly start your screen sharing.
Yes, sir, starting, sir. Sir, am I visible, sir?
Yes.
Excuse me, sir. Sir, uh, respected mentors, my seniors, and all my colleagues, a very good evening to all of you. I'm going to present a paper on the spectrum and magnitude of congenital limb deficiencies in children less than 18 years of age. The limb deficit disorders are a broad group of congenital anomalies, and it features a significant hypoplasia or aplasia of one or more bones of the limbs. It is not an isolated finding, but it represents a spectrum of anomalies having many systemic manifestations apart from the musculoskeletal. In our study, the aim of our study was to study the spectrum and the magnitude of the limb deficiencies in children who visited the Lady Harding OPD and who fall under the age group less than 18 years of age. Sir, our study was an observational study where we considered 34 limbs of children less than 18 years of age, and all the affected children were classified, were assessed by detailed history, clinical examination, and standard AP and lateral X-ray views of affected limb and the contra-limbed limbs. The limb deficiencies was first classified into the transverse and longitudinal deficiencies, and the respective upper limb and lower limb deficiencies were classified according to their respective classifications. In our observation, we found out we included a total of 24 patients, and in those 24 patients, 34 limbs were affected. 16 patients had unilateral involvement, whereas 8 patients, that is 36%, had the bilateral involvement. The age of the mothers of the affected children ranged from 19 to 34 years, and with maximum number of mothers belonging to the age group of 25 to 30 years. And there was no history of any drug exposure or abuse or any history of trauma or any prenatal diagnostic techniques and exposure of radiation to any of the mothers of the affected children. If we talk about the upper limb involvement, we had a total of 8 children who had upper limb involvement, and out of those 8 children, 4 had a unilateral involvement and 4 had bilateral involvements. In upper limb deficiency, we found that the number of patients having radial club hand was maximum. It was the total of 10 limbs had radial club hand deficiencies, whereas one patient had ulnar club hand and one patient has brachydactyly. In terms of terminal deficiency or intercalary deficiency, we had one patient that had we had 4 patients that had terminal deficiency, and 4 limbs that had terminal deficiency and 8 limbs that had intercalary deficiencies. And out of the radial club hand was actually the maximum radial club hand was the most prominent deficiency, or the maximum deficiency that we found. And out of radial club hand, Heikel type 4 deformity was the most common type of radial club hand deficiencies. And all the patients of radial club hand had associated thumb hyperplasia of variable degrees. 4 patients had carpal abnormalities, 1 patient had anal atresia, and 1 patient had associated shortening of the ipsilateral lower limb along with the scoliosis, and 1 patient had the atrial septal defect. If we talk about the lower limb involvement, we had a total of 22 limbs that had lower limb deficiencies, and from from 16 patients. And out of all the lower limb deficiencies, fibular hemimelia was the most common lower limb deficiency that we encountered. And the most common type of fibular hemimelia belonged to the Acterman type 2. And associated anomalies were associated anomalies with fibular hemilia were six limbs had the femoral shortening, 7 patients had equino varus deformity, and 1 patient had a coxa vara deformity at the hip. The fibular hemimelia was followed by the tibial hemimelia and the femoral deficiencies. We had 7 limbs that had tibial hemimelia, and tibial hemimelia was associated with the flexion contracture of the knee, hypoplastic patella, equimovarus deformity at the ankle, shortened femur, hip displacement, and 1 patient also had a mirror foot deformity. This patient had the mirror foot deformity. In terms of, if we talk about the femoral deficiencies, we had 10 limbs that had femoral deficiencies, out of which 3 predominantly had femoral deficiency, whereas others were associated with other anomalies of the lower limb like tibial hemimelia or fibular hemimelia. The most common femoral deficiency belongs to the PAPA class 9, that came out to be 80% of all the femoral deficiencies. If we conclude about the result, the lower limb deficiencies were found to be 2 times more common than the upper limb deficiencies, and unilateral involvement was found to be more common than the bilateral involvement. Overall, terminal longitudinal deficiency was found to be the most common deficiency, which was followed by the intercalated longitudinal deficiencies. And in lower limb deficiency, proportion of fibular hemimelia was found to be the most common deficiency of the lower limb, which was followed by the tibial hemimelia. And in upper limb, radial club hand was found to be the most common deficiencies of the upper limb. At the end, I would like to conclude that limb deficient disorders, it presents a significant amount of burden on and wide range of manifestation, and affected patients may have the various skeletal anomalies as well as systemic anomalies that need to be encountered, sir. Thank you, sir.
Thank you, Dr. Pradeep Mandal. That was a nice presentation.
Thank you, sir.
Yeah, paper is open for discussion. Any questions from anybody? You can stop sharing the screen now.
Yes, sir.
No questions? Then we can move on to the next presenter. Dr. Gaurav Garg, are you there?
Yes, sir, I'm.
Are you ready with the presentation?
Yes, sir.
Okay. Dr. Gaurav will be presenting on comparative study of intra-articular injection of autologous platelet-rich plasma versus intra-articular viscosupplementation in the management of Kellgren and Lawrence grade 2 and 3 osteoarthritis of the knee. You can start, Dr. Gaurav.
Good evening.
Others, please keep the mics in the mute. And the presenters who are present, but their names are not visible on the screen, kindly mention in the chat box that you are there so that we can take your turn now. You can start, Dr. Gaurav.
Good evening, everybody. I am Dr. Gaurav, second year postgraduate resident from ESI Hospital. I am presenting today the comparative study of intra-articular injection of autologous platelet-rich plasma versus intra-articular viscosupplementation in management of KL grade 2 and 3 osteoarthritis knee. Let me introduce you about the burden of the disease in India. Osteoarthritis knee is the second most common rheumatological problem with the prevalence of 22 to 39% in our country. It is more prevalent in women than in men. And its diagnosis can be made by the standard AP and lateral weight-bearing radiograph of the knee joint, which can show the following features depending on the stage. And it is graded by the Kellgren and Lawrence grading system from grade 1 to 4 with increasing severity. And the current standard of care for patients with symptomatic OA, osteoarthritis, include lifestyle modification like weight reduction and diet modifications, and oral anti-inflammatory drugs like NSAIDs, physical therapy like quadriceps strengthening exercises, local ultrasonic TENS or interferential therapy, topical anti-inflammatory gels, or intra-articular injection or surgical intervention like knee arthroplasty or hemiarthroplasty. And hyaluronic acid is a natural constituent of joint fluid. It functions, the current standard of care, hyaluronic acid is a natural constituent of joint fluid. It functions as the primary joint protective component of synovial fluid because it has viscosity as well as elastic properties, affecting both the protective barrier and flow characteristic of synovial fluid. It is first approved in 1997 by FDA, and in our study, we used Hyalin GF20, Synvisc 1 as a hyaluronic acid. And PRP is a blood derivative that aim at concentrating platelet to take advantage of their properties. And once activated, they release a group of biologically active protein that bind to the transmembrane receptor of their target cells, thus leading to expression of gene sequence that ultimately promote cellular recruitment, growth, and morphogenesis, and modulate the inflammation as well. PRP, being a concentrate of platelet, is a rich source of autologous growth factors such as IGF, TGF, VEGF, PDGF, and basic FGF. PRP can affect inflammation and angiogenic process and anabolic and catabolism balance in such a way that cartilage formation is improved and it alters the existing microenvironment during the disease. And we included patients of either sex from 50 to 80 age group with KL grade 2 and 3 osteoarthritis knee with no response to conservative management for at least 3 months. And we excluded the patient with hypersensitivity to hyaluronic and xylocaine. And cases of infection or local skin infection at the injection site, and patients who have received any intra-articular injection within 3 months before the study, and infected joint, uncontrolled diabetic patients, large effusion, pregnant lactating females, and inflammatory joint disease patient. And we divided the patient into 2 groups of 30 patients each by block randomization method. And in patient of group A, we have given intra-articular injection of autologous PRP. In group B, we have given intra-articular viscosupplementation by Synvisc 1. And in the preparation of PRP, we take 6 5 ml syringes to take 30 ml blood. And these 5 ml syringe vacutainer having acid citrate dextrose and subject it to sequential spinning. In first spin, we centrifuge it at 1300 RPM for 10 minutes, which separate it into 3 layers. The bottom layer consisting of RBC, middle layer consisting of buffy coat having leukocyte and platelet, and top layer consisting of plasma with suspended platelets. In the upper 2 layer, approx 2.5 ml from the 5 ml was drawn from each vacutainer into 3 separate sterile 5 ml test tubes. Thus, a total of 15 ml plasma was obtained from 30 ml of blood. And in second spin, these 3 test tubes of 15 ml was centrifuged again at 3500 RPM for 10 minutes. And after this centrifugation, there will be 2 parts. The top half containing of platelet poor plasma, and the bottom half contain platelets and leukocyte at the bottom. And the injection were given under strict aseptic condition through supralateral approach after giving local infiltration of 2% xylocaine after sensitivity testing. And post-procedure, we have advised patient to avoid excessive weight bearing and strenuous exercise for next 2 days, cold compression, SOS analgesics. Follow-up was done at the interval of 1 month, 3 months, and 6 months via VAS and KSS score. And as the result shows, there was decrease in mean VAS score and mean KSS score between pre-injection and at the 24th week in both the group. But the result of decreased VAS score and increased KSS score was significant in group A, that is PRP group, with respect to group B, that is hyaluronic acid group. And knee osteoarthritis is characterized by degeneration of articular cartilage. And research have shown that osteoarthritis is not simply a chemical process, but catabolic cytokines cascade and production of inflammatory mediator also play a significant role and should be targeted for intervention as we do in PRP. The basic principle underlying PRP therapeutic activity is the release of collection of growth factor and other signaling polypeptide into the joint microenvironment. And we conclude that result shown that the PRP is an effective measure in improving pain, stiffness, and overall physical function in mild to moderate ONE as compared to hyaluronic acid. And PRP is a simple, low-cost, and minimally invasive method that provide natural concentrate of autologous growth factor from the blood. Thank you.
Thank you, Dr. Gaurav Gupta, for a nice presentation. The paper is open for discussion. Any questions? Dr. Gaurav, have you compared the results with the injection depomedrol also?
No, sir. We have compared result of injection platelet-rich plasma with that of the viscosupplementation with hyaluronic only.
Okay. How many injections have you given?
30 patients for hyaluronic acid, sir, and 30 for platelet-rich plasma.
Okay. All right. If there's no questions, we can move to the next speaker. Thank you, Dr. Gaurav.
Thank you, sir.
So, Dr. Prem Kumar is there?
Yes, sir.
Yeah. You can unmute yourself.
Yes, sir.
Yeah. Start your presentation. Dr. Prem Kumar will be presenting on functional outcome of arthroscopic ACL reconstruction with anterolateral ligament reconstruction for anterolateral knee instability. You can start, Doctor.
Okay, sir. Good evening, sir. My subject is functional outcome of arthroscopic anterior cruciate ligament reconstruction with anterolateral ligament reconstruction for anterolateral knee instability. ALL is a ligament on lateral side of knee, which also contributes to stability of knee like ACL. Its significance is it stabilizes the medial rotation of knee in addition to ACL. Its reconstruction provides a reinforcement to the ACL reconstruction, especially in high demand athletes and in knees with high grade pivot shift. Hello?
Yeah, we are able to listen to you. Continue.
So my sample size is 16 patients, which includes of all symptomatic ACL injuries with pivot shift with grade more than 3 or equal to more than 3. And the exclusion criteria is ACL injury due to bony avulsion, tear in osteoarthritic knee, and skeletal immature patients, or if there are any sign of infection. We have pick up the pivot shift grading and lysome 2 scoring for the assessment at the follow-ups at 3 and 6 months. These are the photographs showing the formation of femoral tunnel and tibial tunnel for the placement of graft for AL reconstruction. And then my observations and results are, it includes 14 males and 2 female patients. The age range is 15 to 30 years with mean age of 24.8 years. Left knee is more injured than right knee, and RT is the most common mode of injury. All patients were positive for anti-drawer and latchment test, pre-operatively and intraoperatively done under anesthesia. Valgus varus posterior drawer negative in all patients. On MRI, ACL tear in all patients associated with meniscal tear in 5 patients, and there is no PCL or any other injury. So these are the tables showing the pivot shift grading of the patients pre-operatively. Here, it is negative in 6.3% patients, where it is more than 3 in 50% of patients when we done pre-operatively without anesthesia. But when we done under this test under GA, all patients are more than grade 3 pivot shift grading. And the mean lysome score of the all patients pre-operatively is 54 point plus minus 5. Post-operative follow-up at 3 and 6 months were done. The same patient was positive at the end of 3 and 6 months after the surgery for anterior drawer and latchment test due to post-operative acute infection. And this is the pivot shift grading improvement in the patients at regular follow-ups. Post-operatively, improvement in lysome score is significant and p-value is less than 0.001. Sir, the most affected age group is 21 to 30 years. And there are 10 out of 16 patients. And this is gone with the literature that ACL is more common in young physically active individuals. In our series, only 14 males were reported with ACL tear, and this male dominance is due to more outdoor activity, sports participation, and uses of more vehicles. There is no particular limb is at high risk. In our study, 11 patients had injury in their left knee and 5 had a tear in right knee. RT is the most common cause due to relatively less sports activity in our region and very high rates of RTA, like bike riding. ALL lesions identified clinically by pivot shift grading, performed prior and after anesthesia. All patients with pivot shift grade 3 considered to have ALL lesion. ALL lesions could not be identified on MRI due to lack of sensitivity of radiologists towards ALL anatomy and lesion. The injury to ALL, medial or lateral meniscus, is associated with high level of pivot shift. In our study, 5 patients had meniscal tears on MRI, and all these patients have high pivot shift grade, which is more than equal to 3. In our study, only 50% of patients showed pivot shift grade more than 3, and on examination under anesthesia, all patients found to have pivot shift grade more than equal to 3. This is a statistically significant difference found, and conclude that pivot shift is not a reliable clinical test for measuring ventilator stability, for rotatory stability, for ACL deficient knee when done without anesthesia or an awake patient. In both follow-ups, anterior drawer and Latchman was positive only in one same patient due to post-operative infection of surgical site and then about the pivot shift grade test, ALL is only affect the pivot shift grading. One same patient remain grade for more than 3 for pivot shift on both follow-up tests due to post-operative acute surgical site infection of femoral side. 3 patients examined were pivot shift grade 2, 1 with grade 1, and rest are negative after the surgery. So after combined surgery, post-operatively, pivot shift grading improved in study population. The Lysome 2 scoring, the various studies explained that combined ACL and ALL surgery is associated with excellent outcomes in professional athletes with respect to graft rupture rates, return to sport, knee stability, and reoperation rates. Subjective effectiveness of this procedure was gauged by the comparing the Lysome knee scoring method, and this technique scores high on clinical outcome as depicted by Lysome score. In our study, mean Lysome score preoperative is 54, where it is improved to 90 and 94 at follow-ups at 3 or 6 months. These values are comparable to the literature at 6 months of follow-up and stand excellent for this reconstruction technique. The difference in pre-op and post-op Lysome score was statistically significant with p-value less than 0.01. After combined surgery, limb instability support for walking and locking reduced and improved the post-operative scoring. The complication is ALL graft was secured into its bone socket using screw on femoral side in 13 cases, while in rest of the 3 cases, endo button is used on the femoral side. One patient experienced pain and swelling localized to the external aperture of femoral tunnel, and after 1 month surgery, endo button on femoral side of graft removed, lavage done and proper cover of antibiotics given, and then after implant removal, pain and swelling subsided with improved range of motion. The limitation of studies, a larger sample is required for more definite result, and long follow-ups are required, approximately 3 to 4 years for exact findings. So we conclude that combined ACL-ALL injury resulted in a favorable functional outcome in anterolateral stability of knee in terms of improvement in pivot shift grading and Lysome 2 scoring. The method, although requiring a good surgical expertise and knowledge of anatomy of ALL, can be definitely advocated as a novel method for good results following arthroscopic ACL and of ACL TR patients with high-grade anterolateral stability. Thank you, sir.
Thank you, Dr. Prem, for a nice presentation. Yeah, paper is open for discussion. You can stop sharing the screen. Any questions from anybody?
I have one question.
Yes, doctor. Dr. Sikand.
Dr. Saab, can you hear me?
Yes, sir.
In your study, in 6.3% of the cases, the pivot shift was grade 1.
Yes, sir.
So do you do ALL reconstruction for grade 1 pivot shift?
No, sir. Sir, in the literature, it is said that if pivot shift is approximately up to grade 2, so clinically we can suggest that there is ALL is not teared or ALL is not injured, sir. So a patient which have a up to grade 3 or more than grade 3 pivot shift grading is clinically suggestive of ALL lesion, sir.
But you have included 6.3% patients with grade 1 pivot shift test.
Sir, we are not including post-operative after the ALL reconstruction. Sir, still the grade is not improving, sir. These are the patients which are not improving after the reconstruction also. And sir, pre-operatively, when we done this pivot shift grading without in the awake patient or without anesthesia, and after anesthesia, the grading has been changed so much after the anesthesia. So, sir, this is also a point that we should done the pivot shift grading under anesthesia for accurate grading, sir.
So you recommend doing a pivot shift test under anesthesia before
Yes, sir.
deciding to add ALL or not?
Yes, sir.
Okay.
I kindly stop sharing the screen, doctor.
Yes, sir.
Any other question? Okay, if there's no question, thank you, Dr. Prem, for presentation. We move on to the next paper. Dr. Manish Yadav is there. Dr. Manish Yadav. I think he's not responding. Otherwise, he's there. I could see the name. There is Dr. Ankur Patel in my list. I think somebody is asking with the name of Dr. Kishan Patel. Is it the same person or different? Dr. Ankur Patel.
I think he's not there. How many are remaining, Barjinder?
There should be a total of 11 persons in my list, out of which 8 have already spoken. Dr.
Okay.
Manish is there waiting in the list, but I think he's not responding.
Do we conclude the session?
That's what I'm thinking, but there were 2 queries from 2 speakers. I think there might be some confusion in their listings because we have still time. If they want to present, if anybody is left and he wants to present, we can allow him. Because of these last moment changes, there might be some confusion.
Actually, we have 40 minutes of time. So because we cannot end this session, because we have to continue the session by 6 o'clock. So if anybody else wants to present, he can do so.
Yeah, that's what I'm saying. Because 2 persons were asking whose name were not there. If they are willing to present, we can allow them.
One was that first name, Dr. What was
Dr.
his name?
Rahman.
Dr.
I don't
Rahman,
know
are
now.
you there?
It's not visible now. And one was Dr. Patel. But the name in my list is Ankur Patel. So if it is another Patel, doesn't matter, he can present. Dr. Kishan Patel, are you there?
Dr. Aditya Tripathi has put some message on the chat. Just look into it. My name is 6th to 8th list. Is in the 6th to 8th list. Aditya Tripathi. Dr. Aditya Tripathi, are you there? Yes, he is there. Dr. Aditya Tripathi.
Yes, sir.
You want to present?
Sir, my name is in 6 to 8. I can present, sir.
No, no, you are name. No, but his name is in 6 to 8.
Yes, sir.
It doesn't matter. We have time.
Okay. You present, please.
Yeah, you can present, doctor.
Okay.
Sorry, sir. There is some difficulty in sharing the screen. I am just doing it. Hello.
Yes, doctor.
Sir, there is some difficulty in sharing the screen. I'll just sort it out and I'll let you know, sir. Sorry, sir.
Okay. Anybody else who wants to present in this session?
We can let him present in his regular session if he's finding it problematic now.
Yeah. Let him take his time. Anybody else who has left and who wants to present? Because we have time. Dr. Manish is there, I think. Manish Yadav. Dr. Manish, can you hear me?
Yes.
Are you ready with the presentation?
Give me 2 minutes, sir.
Okay. You can start. Dr. Manish Yadav will be presenting on comparative study of core decompression with autologous iliac crest bone graft versus bone marrow infiltration in osteonecrosis of femoral head. You can start sharing the screen, doctor.
शेयर का कोई शेयर कहाँ था इसमें
बोलो कैसे शेयर नहीं हो रहा
बोलो सुन ही रहे हैं
सर भी शेयर नहीं हो रहा 2 मिनट को हेलो
यस
सर अभी थोड़ा सा टाइम लगेगा शेयर नहीं हो रहा थोड़ा सा
ये
Okay, we can see your screen now.
Sir, can you see me my slides?
Yes, you can start.
Yes, sir. Good evening, sir. I am presenting the comparative study autologous iliac crest bone graft versus bone marrow infiltration in osteonecrosis of femoral head. I am Manish Kumar, PG third year. My guide is Upi Lakhwani. Introduction. Osteonecrosis of femoral head is a aseptic ischemic necrosis of femoral head. It is a refractory disease characterized by the compromised subchondral microcirculation.
Yeah, continue. We can listen.
It is a refractory disease characterized by the compromised subchondral microcirculation leading to necrosis of bone. It is a progressive destruction and alteration of bone architecture leads to microfracture and finally deterioration in the joint function. Aim and objective are to compare the outcome of core decompression with autologous iliac crest bone graft versus bone marrow infiltration in the term of firstly functional outcome by Barry score and was score, pain analysis score. Second is radiological outcome by MRI and X-ray.
This will be coming. Your video will come like this twice.
Our material method. Our study is a prospective and international randomized comparative study. Study area SIP JSMR. Duration October 2018 to 220 January 2020. Study population minimum 20 hips, either sex between the age 18 to 15 years. Inclusion criteria, both genders, age between 18 to 15 years. Stage 2, 3 Fickett alert and ARCO classification. And exclusion criteria, avascular necrosis of femoral head with implant in situ, age less than 18 years, history of major hip trauma, history of blood hysteresis. Mainly divided into patient 2 groups, randomized into 2 groups using a sample random number table method. Group A, core decompression 5 to mm with autologous iliac crest bone graft uses. Group B, multiple small T3.2 drill use core decompression with bone marrow infiltration done. Figure 1 generally figures show only use of instrument in core decomposition, bone marrow respiration, and iliac crest bone graft. Figure 2 show the core decomposition procedure in femoral head under the Siam guideline. Figure 3 show intra Siam guidance X-ray AP view, and 4 show lateral view of the proximal head showing insertion of guide wire toward the necrotic area. Our results. Firstly, compare the comparison of Hipari score between the groups. In the comparison of mean change in Hipari score pre-op to subsequent time period group, there was no group A. There was no significant mean change in group A. But however, there is significant mean change in Hipari score and group B pre-op to 3 months and pre-op to 6 months. Mean change in Hipari score better than group B than A. The second group comparison of VAS score between the groups. In comparison, A group there is no subsequent change in VAS score, significant change. But B group there is significant change in pre-op to 3 months and pre-op to 6 months. And third is there is no radiological X-ray change in pre-op and post-op after follow-up 6 months, and there is no radiological MRI change in between pre-op and post-op after 6 months. Conclusion: we conclude that our core decomposition with bone marrow infiltration is better to iliac crest bone graft because the better Hipari score and VAS score at 6 months. However, consider the limitation of our study. More study with larger sample size required to conclusively support the finding. The references. Thank you.
Thank you, Dr. Manish, for a crisp and short presentation. That was a nice one. Any questions on that? No questions? So we have one request from the next session speaker, Dr. Joe Lordu Pradeep. He wants to present on. Yeah. Are you ready with the presentation?
Yes, sir.
Dr.
Can I share my
Pradeep will
screen?
be presenting on D. curvans stenosynovitis. You
Yes,
can
sir.
start
Yes, sir.
sharing, doctor.
Yes, sir. Can I present, sir?
Yeah, you can start.
Good evening, everyone. My topic is on, today's presentation is on a prospective study on effectiveness of methyl prednisolone acetate injection plus casting versus casting alone for the treatment of decurrent tenosynovitis. Decurrent tenosynovitis is a condition characterized by thickening of and by the accumulation of mucopolysaccharide in the sheath of the abductor pollicis longus and extensor pollicis brevis tendons, which cross under the extensor retinaculum in the first dorsal compartment of the wrist. The extensor retinaculum is a fibrous band attached to the underlying radius, which prevents bowstringing of the extensor tendons of the dorsum of the wrist. The condition takes its names from the Swiss physician de Quervain, who first described a case series of 5 patients in 1895. Its prevalence is 0.5% among men and 1.3% among women. It is considered as a work-related musculoskeletal disorder of the upper limb. The differential diagnoses of it are osteoarthritis of first carpometacarpal joint, ganglia, infectious tenosynovitis, Wartenberg syndrome, and intersection syndrome. The patient typically complains of pain over the radial styloid process, which is likely caused by mechanical friction as the tendon passes through it's narrowed by the compartment. On clinical examination, there is tenderness over radial side of the wrist, and symptoms can be elicited by Finkelstein's test. The various management options are non-surgical modalities like casting, ice pack application, non-steroidal anti-inflammatory drugs, therapeutic exercise, and splinting. Corticosteroid injection is the mainstay of treatment for those patients who do not respond to the above. Other described treatments include hyaluronic acid injections, USG-guided percutaneous needle tenotomy, and PRP injection, and prolotherapy. Surgery is reserved for failure of conservative modalities and involves release of the first dorsal compartment. My aims and objectives. This study was performed to compare the outcome of methylprednisolone acetate injection plus thumb spica cast versus cast alone for the treatment of decurrent tenosynovitis. Mine is a randomized controlled trial. The diagnosis of disease was based on 3 clinical findings, including pain at the radial wrist with resisted extension or abduction of the thumb, tenderness at the first dorsal extensor compartment over the styloid process of the radius, and the positive Finkelstein's test. Patients with a previous history of acute trauma, wrist fracture, steroid injection, pregnancy, and rheumatoid arthritis were excluded from my study. Finkelstein's test was performed as a more pathognomic objective sign in the diagnosis of this disease. It was considered positive when passive ulnar deviation of the hand with thumb and fingers in palmar-flex position provoke pain over the styloid tip of the radius. All patients were given explanation of the nature of disease and plan of treatment. Written informed consents were given by all patients. Patients were randomly assigned based on
your
the
slides are not moving. May I interrupt you? The slides are not moving.
Sir, now, sir?
Yeah, now it's moving.
A total of 40 patients with the decurrent tenosynovitis were managed with either of these methods. In the first group, I included injection of methylprednisolone acetate in the first dorsal compartment of the wrist, followed by wrist thumb spica cast and casting alone. The wrist casting duration in both the groups were 1 month, and the patients were followed up during 6 weeks and 12 weeks. In my profile, there were 20 patients involving the methylprednisolone acetate injection and thumb spica cast, and 20 patients only cast. Among that, female were more in amount. Then age was around in the 4th decade. Then right and left limb were equally involved. Here is a list of patients I am explaining, where group A 20 patients and group B 20 patients. Among these, 5 patients had comorbidities of diabetes and 2 patients had hypertension. Female are more involved, and age it is more. It was 9 in 5th decade. Now, association between the VAS code in my group. At the initial presentation, in both the groups, they had persistent pain. Whereas at the 6th week, it was seen that the patients for whom thumb spica and steroid were given, there was a significant reduction of 17, that is 85%. And similar, whereas in the casting alone, it was 20% who had persistent pain. Similarly, in the 12th week, 20 patients had that is 100% of the patient had pain reduction for thumb spica and steroid, whereas in the casting group 7 patients had pain reduction. Discussion. Currently, the common treatment modalities for decurrent disease are non-operative and consist of modification of wrist activities, analgesic drugs, corticosteroid, bracing, casting, and physical therapy. Surgery is reserved only for those with intense chronic pain unresponsive to conservative treatment. This study had revealed that more patients respond favorably to methylprednisolone acetate injection. The effectiveness of corticosteroid therapy is attributed to the inflammatory effects of this drug, but the exact mechanism of action remains unclear. In the systematic review of effectiveness of corticosteroid injection for decurrent tenosynovitis performed by Ritchie and Ernier, that included 7 observational studies with 459 risks, it was determined that 83% of 226 risks which received injection alone were cured. 61% of the 101 risks that received injection and splint immobilization were cured, and 14% of the patients who received splinting alone were cured. In a study by Kitty et al., the success rate with steroid injection was 67%. Limitations of my study are: the limitations of my study is short time follow-up, therefore the recurrence rate was not possible to assess. Thus, a future study will be needed. Another limitation of my study is it's a non-blinding method of the study. Conclusion. It is concluded that the injection of methylprednisolone acetate in the plus a thumb spica cast was more effective than casting alone in the treatment of decurrent tenosynovitis. Application of prefabricated removable thumb holder and wrist splint for a short period of time may be preferred in patients that complain of pain after local steroid injection. This is my master chart, sir, and these are my bibliography and my acknowledgement.
Thank you,
Thank
Dr.
you, sir. Thank you, sir.
This was a nice presentation, short and crisp. Paper is open for discussions. Any questions? You can stop sharing the screen now.
Okay. Yes, sir. Thank you.
We can take any questions. No questions. Thank you, Doctor. We move on to the next paper. Dr.
Thank you, sir.
Obaidur Rahman is there. Dr. Rahman, are you there? Are you ready with the presentation? We can't hear you. Kindly unmute. Dr. Rahman will be presenting on association of pelvic sagittal motion and acetabular cup positioning in total hip arthroplasty. You can start, Doctor. Your voice is not there clear.
A very good evening to all of you, sir. Can I start, sir?
Your voice is not clear, Dr.
Yes, sir.
Rahman.
Yes, sir. Am I audible, sir?
Yeah, it's better now.
Yes, sir. So, the title of my study is Association between Increased Sagittal Pelvic Plane Motion and Functional Positioning of the Acetabular Cup in Total Hip Arthroplasty. Coming to the introduction, the total hip arthroplasty is the most commonly performed adult reconstructive hip operation. Acetabular cup placement has to be done within proper orientation in order to prevent dislocation and to decrease wear and increase longevity. Given that the acetabular cup malpositioning is stated to be fairly high, the pelvic sagittal plane motion has a variable effect on the outcomes of THR, as it mainly affects the acetabular component. Eventually, we have to prevent the dislocation. By placing the acetabular cup within the so-called safe zone, which is defined as inclination of around 30 to 50 degrees, anteversion of around 10 to 13 degrees. But due to dynamic posture of the individual, the well-positioned acetabular cup in the supine posture could in turn become malpositioned once the patient assumes the standing decubitus. Coming to the aims and objective of the study, to study the association between the increased sagittal pelvic plane motion and altered functional positioning of the acetabular cup during total hip replacement. Material method was Department of Orthopedics, PGIMR, Dr. RML Hospital, New Delhi. The study design was prospective observational study. Study period was from 1st October 2018 to 31st March of 2020. And the last case was to be recruited on before 31st December 2019. The sample size was minimum of around 20 subjects. So here is the X-ray depicting the angle measurement which I've taken in the pre-op X-rays in order to measurement the pelvic sagittal motion. This is the lumbar lordotic angle and the tilt in the patients whose acetabular cup was placed in the safe zone and outside the safe zone respectively. Now, coming to the eligibility criteria, the inclusion criteria was patient with end-stage osteoarthritis of hip joint, stage 3 and stage 4 of Kellgren-Lawrence of either sexes, 44 years and above, posted for THR. The exclusion criteria were patients who required constrained acetabular cup, revision total hip replacement, patient who had undergone prior osteotomy or arthrotomy involving the hip joint, or patient with morbid obesity. Coming to the result of the study, around 20 patients of 20 were included in the present study after obtaining the informed consent from all the patients. Study included 13 male and 7 female, with male to female ratio of 2:1. The mean age of the males were 59.46 plus minus 9.86 years, and a female were 57.57. The side of injury was 12 on the right side, and the side of involvement of THR was 12 on the right side and 8 on the left side. And coming to the gender distribution was around 35% were females and 65% were males, and 40% were the left-sided. And the participation frequency around 45 to 50 years were 5 patients we had, 55 to 60 were 6 patients, and 61 to 70 were 8 patients, and above 70 we had only 2 patients. And coming to the preoperative pelvic tilt in degree in lateral radiography in sitting position, was the mean was found to be 19.67 degree, and in pelvic tilt in standing posture was 11.52 degree, and the standard deviation was 2.44. The lumbar lordotic angle, the mean in standing posture was 65.15 degree, and in the sitting flex posture was 47.7. Now the difference between the groups were the mean of the group between standing pelvic tilt and sitting pelvic tilt was 11.96 and 25.3 respectively, out of which the difference in the pelvic tilt in standing and sitting flexed position, when it was found to be less than 11 degree, then the angle of cup intraoperatively was that is 10 degree. And we had seen three patients, the pelvic tilt was measured, difference in pelvic tilt between standing and sitting flexed was found to be more than 11 degree, and around three patients were kept outside the safe zone, that is outside the acetabular cup in anteversion of 10 to 13 degree. So around 85% patients were between the cups were placed within the safe zone, and 15% patients the cup was placed outside the safe zone. And the outcome was then elicited by modified Harris-Hip score, and Harris-Hip score was found to be 77 was the mean Harris-Hip score, and the Harris score in patients with the acetabular cup in the safe zone were around 75, and with outside safe zone was 71. So both were comparable. Coming to the discussion aspect, it is important to find the optimal cup positioning, and which in most of the cases restoring the original hip rotation, center and target 40 degree inclination, 10 to 30 degree of anteversion. In the study conducted by us, total hip arthroplasty was done in 12 cases on the right side and 8 on the left side. The mean preoperative pelvic tilt on lateral radiography in standing was found to be 11.52, whereas mean perioperative pelvic tilt in lateral radiography in sitting flex posture was found to be 19.67. In our present study, we have kept the acetabular cup anteversion in 10 to 30 degree in 17 patients, and 3 were kept outside the safe zone. The patients kept in the safe zone were kept in the anteversion of 35 degrees, which is 5 degrees outside the safe zone. Coming to the conclusion, our study suggests that there is excellent outcome on the modified Harris-Hip score points with acetabular cup angle kept in safe zone. There are minimal complication observed in the present study. The overall functional and clinical outcome showed good results. And this is the brief summary of by study. Since there was no difference in the modified Harris-Hip score of males and females, which was found to be almost on par with both of them, and mean modified Harris-Hip score was found to be 77.62 in the present study. Thank you.
Thank you, Dr. Rahman, for a nice presentation. The paper is open for discussion now. Any questions?
Dr. Rahman?
Yes, sir.
I'm sorry, your slides were either coming too small for me to read, but did you have any of your patients in which the patient had a previous spine surgery or the spine was fused?
No, sir. Actually, we had 2 patients of ankylosing spondylitis which fused spine, but the pelvic sagittal motion, the difference between the pelvic sagittal motion was less than 11 degrees. So we kept the acetabular cup both in the safe zone.
So the idea of having talking about spinopelvic obliquity affecting how you're going to close your cup is all about the fused spines. When the spine motion is normal, do you think this actually makes any difference in how you're going to place your cup?
No, sir. When the spine motion is normal, then it's fine. But if any condition with increased spinopelvic motion, sagittal motion, in that case, it will play an important role in placing the acetabular cup, because if the spinal pelvic motion, the tilt varies a lot from standing and sitting flex position, then in that case, the patient, when there is a dynamic motion in the patient, for example, the patient is in supine posture, and when he stands, so there is a functional change in the acetabular cup positioning, which could lead to edge loading or probably at worst condition dislocation also.
बाकी सबका भी दिखता है क्या चल रहा है? Actually, that's not what I asked, beta. If the spinal pelvic motion is increased or decreased?
Yes, sir.
No. You said it, if it is increased, then there is an abnormal motion at the acetabular.
No, sir. I said the difference between the standing and the sitting flex positions, spinopelvic motion increases. The difference between the standing and the sitting flex.
My question is slightly different. Just hear my question once.
Yes, sir.
In sitting and standing position, the inclination of the acetabulum changes because there is a spinopelvic motion.
Yes, sir.
In patients who have a fused spine, like ankylosing spondylitis, or patients who had a previous surgery done at L5-S1 levels, who have a fused lower
Yes,
segment
sir.
of the spine, this motion reduces at the
Yes, sir.
spinal level and increases at the pelvis level. Hence, the
Yes, sir.
tabular inclination changes.
Yes, sir. Exactly.
So in your study, only 2 patients were of fused spines. That is what you're
Yes,
saying.
sir. Yes, sir. Only
And
2
because their
patients.
spinopelvic motion was normal, you did not change anything.
Yes, sir. We couldn't change because the different
Okay.
the
Fair enough.
guidelines what we.
Okay.
Yes, sir. Okay.
Okay.
Any other question? If there's no question, thank you, Dr. Rahman.
Thank you, sir.
Any other speaker left? I think we have completed our list. All those who present, they have done their job nicely.
We have 10 minutes now.
I think our list is complete.
Okay.
We have already taken 2 extra speakers from the 6 to 8 session also.
So I think who are the chairperson for the second session?
Should
We
be
can
Dr.
start the-
Harmesh. Dr. Harmesh should be one of them.
उनको इंटरफेरेंस पूरा आता है ना, दूर नहीं जी, वो भी बैठना पड़ेगा मुझे कुछ.
Just call Harmesh, Dr. Barjinder.
Okay. So they will log in the same ID password or they have a different ID password?
Same, this one.
Okay. Let me call.
Dr. Dhawan, we hand over the session to the next team.
Yeah. We are just waiting for Harmesh, and then we hand over to him. I think Harmesh has to take over the.
यहाँ से शेयर स्क्रीन में जाके अपना
Dr. Barjinder, Dr. Sumit Sural and Dr. BP Sharma are also chairpersons.
Let them take over and start the next session.
Yeah, let them, they can start now.
So we thank all the participants, presenters, and all the faculty members for this session. And shall we close the session now?
No, we cannot close the window. We can, close the session, but I think just 7 minutes are remaining. So let the next team come.
Dr. Harmesh will take 5 minutes. If the Dr. BP Sharma and others are there they can start. Let's see if there are speakers from the next session.
Can we let, sir?
Dr. BP Sharma.
Yeah, he's there.
He's there.
Sir, even I am Dr. Chandeep Singh. I am one of the panelists as well. I'll take
over. You take over, sir. Because I think we can start at least one presentation, sir.
Okay. So, good evening, everybody. And a wonderfully well session conducted by Dr. Barjinder and Dr. Sikand. And thank you to the chairpersons, Dr. Dhawan and all of them. Anybody present, because we already had 2 people who have already presented from the 6 to 8. Dr. Obedur has presented and Dr. Joe Lordu Pradeep have presented. I'm sorry if I'm not pronouncing your names correctly. Anybody else present? Mr. Dr. Amit Lakhani, Dr. Sandesh Agarwal, Dr. Aditya Tripathi. Can you just come on the chat? Dr. Yash. Anybody present? I don't think I can't see anybody present, sir. Right now, we'll have to just wait for a while, I guess.
Okay. Dr. Pratik Mandal has already presented, I think. Ayush Bhargava has presented.
Good evening, sir.
Yeah, Dr. Tripathi, you have presented.
Yes, sir. No, sir.
No, Dr. Aditya Tripathi, are you there? Would you like to present?
Yes, sir. Yes, I am ready to present.
So Dr. Tripathi is going to present. His topic is to study the results of only posterior decompression and fixation in dorsal lumbar tuberculosis spine in view of neurological status, amount of fusion, amount of correction of kyphotic deformity, and lifestyle status over a period of time. Dr. Tripathi, please share your screen and please start.
Good evening, sir. Is my presentation is visible?
Yeah, Dr. Tripathi, please go ahead.
ये पता है क्या होता है ये लोग सब है ना
Good evening, sir.
कोई भी रहना
Good evening to all of you.
कोई भी रहना तो पकड़
Dr. Yash, please mute yourself. Dr. Yash, please mute yourself.
Sir, I'm here to present. My topic of the presentation is to study the outcome of single stage posterior decompression and fixation for dorsal lumbar spine tuberculosis. Sir, I am myself Aditya Tripathi. I am a PG resident in New Civil Hospital, Surat, and my guide is Dr. Harish Menon. Sir, as you all know, tuberculosis is the largest infectious cause of death in India, and most commonly it involves the lung, but extrapulmonary sites are frequent too. Recent increase in the incidence is due to concomitant tuberculosis with HIV infection and drug resistance. Of these, 1 to 3% constitutes the skeletal involvement. Spinal tuberculosis is the most common form of skeletal tuberculosis. Spinal tuberculosis involves intervertebral disc and vertebral body, hence it is called spondylodiscitis. Treatment of tuberculosis of the spine has evolved from pre-tubercular era to post-anti-tubercular era, from anti-tubercular drugs to radical surgery to mid-path regimen. Tuberculosis of dorsal and lumbar region causes destruction of anterior column of spine, which result in kyphosis, instability, and late onset weakness. Tuberculosis of dorsal and lumbar region causes destruction of anterior column of spine, which result in kyphosis, instability, and late onset weakness. Kyphosis due to tuberculosis is an unstable lesion that tends to progress at least until there is a complete body fusion anteriorly. The wide lesion, abscess formation, sinus, vertebral deformities, and neurological deficits due to spinal tuberculosis should be treated surgically. If there are no complications and if the lesion is limited to the vertebra, anti-tubercular drugs can treat tuberculosis. Traditionally, the anterior approach is the gold standard approach because vertebral bodies and disc spaces are most commonly affected, and the anterior approach allows direct access to the diseased vertebral bodies for debridement and abscess drainage, allows wide decompression and reconstruction of the defect. In the thoracic and lumbar region, morbidity and complication associated with the anterior surgery are very significant. Anterior instrumentation to provide bone stability may be difficult because the osteoporosis and infection makes the vertebra structurally weak, which prevents adequate stable fixation. A combined anterior debridement and posterior instrumentation helps to overcome stability related drawbacks of the anterior approach alone. However, it requires 2 surgeries with additional morbidity and is indicated for patients with significant deformity. In posterior approach, anterior and lateral column can be reached through extrapleural approach. Posterior approach provides excellent exposure for circumferential spinal cord decompression, allows multiple level posterior instrumentation above and below the level of pathology, more stable construct we can form, less morbid surgery, allows earlier rehabilitation, better deformity correction, and it's a familiar approach. Our aims and objective was to assess the clinical outcome in operated patient of dorsal lumbar spine tuberculosis in terms of pain, deformity, neurology, to assess radiological outcome in terms of fusion and implant stability, and to assess the duration of the anti-tubercular drugs. Materials and methods. We have included 30 patients in our scenario. Inclusion criteria was all patients were admitted in our hospital in 2018 and 2020 session. Age group was 18 to 60 years. Tuberculosis of dorsal and lumbar spine with or without instability. Patient responding to conservative management. Patient not responding to conservative management. Patient with tuberculosis of spine with neurological signs that are not improving or worsening within 4 weeks of adequate conservative management. Progressive neurological deficit even on adequate treatment or recurrence of the neurological signs after improvement, and rapid or late onset paraplegia. Exclusion criteria was multi-segmental tuberculosis, age below 18 and above 60 years, tuberculous spine with other coexisting pathologies, and patient responding to anti-tubercular drugs. All patients were diagnosed on the basis of clinical symptom, X-ray, MRI, or USG-guided aspirate, CV-NAT of the USG-guided aspirate, or CT-guided biopsy. All patients were operated with single posterior approach for decompression, stabilization, deformity correction, fusion of the tuberculous spine. Preoperatively and postoperatively, ESR, visual analog pain score, Osworthy disability index, ODI score, Frankel grade, and kyphotic correction was compared. In operative procedure, patient was positioned in prone position and via posterior approach, surgical exposure was done and decompression was done. Pus and granulation tissue was evacuated and sent for the appropriate culture. Bone graft was harvested and stabilization and pedicle screw fixation done. All samples were collected during surgery, was sent for the CVNAT and biopsy accordingly. And as per sensitivity report, AKT was started approximately for 1 year. All intraoperative collected samples sent for CVNAT biopsy accordingly. Post-operatively, as long as patient's pain was disappeared, he or she was mobilized. Muscle strengthening exercise as soon as pain was subside. Forward and backward bending after radiological healing. Patient with neurological deficit mobilized with supporting aids. Post of follow, patient are allowed followed up at 6 months and 1 year. Every 6 months evaluated for blood investigation, visual analog scale, functional outcome evaluated by post-operative Frankel grading, Osworthy disability index, definitive fusion assessed after completion of AKT by Bridwell fusion score. During follow-up on the basis of clinical improvement and radiological evidence of disease regression like resolution of abscess, inflammation on MRI, along with the evidence of fusion, duration of AKT decided. And the results, there was slight male preponderance with 16 to 14, and most common age group was involved second to third decade of life, which could be due to higher outdoor activities. And then most common presentation in all patients was pain. Thoracolumbar spine is the most commonly affected in our sample, and there was average VAS score was pre-op VAS score was 7.9, which after 3 weeks of the post-op was 2.1, and at 6 months it was 1.1, and at 1 year average score was improved to 0.9. Mean ESR pre-op was 90, and it was improved to after 6 months 45, and after 1 year 30. And kyphotic angle, there was in our study 9 patients had kyphotic deformity, and average angle was 77.9. On 1 year post of follow-up, angle was improved to 9.5. And yes, you can see there is improvement in the Frankel grade during follow-up, and there is a progressive improvement in ODI score during our follow-up, 1 year follow-up. Histopathologically, on examination, introp sample of 30 patients suggestive of rifampicin sensitive tuberculosis, and AKT was started accordingly. Duration of AKT was decided on the basis of clinical signs of improvement, laboratory investigation, radiological evidence of disease regression. Out of 30 patients, 28 patients showed good size of fusion as per Bridwell score at the end of follow-up. In complication perspective, 3 patients had wound-related complication, 2 patients had implant-related complication, and 2 patients had delayed fusion. 3 patients developed superficial wound infection, which 2 healed by conservative management and extended antibiotic therapy. 1 patient was taken for debridement. On 12 months of follow-up, 1 patient developed loosening of 2 distal screws. On 14-month follow-up, 1 patient developed implant impingement, and on 12-month follow-up of MRI, 2 patients showed signs of delayed fusion. Discussion: treatment of tuberculosis spine consists of conservative method and surgical management. Conservative method require long period of immobilization, leads to the complication of prolonged recumbency, and it cannot prevent the progression of kyphotic deformity. The goals of surgery in tuberculosis of thoracic and lumbar spine are adequate decompression, adequate debridement, maintenance and reinforcement of stability and correction, and to stop the progression of kyphosis. For decompression, there are 2 approaches, anterior and posterior. Anterior approach for decompression is gold standard, as TB involves more the anterior part of the vertebra. The disadvantage of anterior approach are morbidity and mortality associated with the transpleural and retroperitoneal approach like atelectasis, chest infection, pneumothorax, and postoperative ileus. The stability of the anterior instrumentation is not adequate fixation, as there is concomitant inflammation associated with the infection, and the anterior bones are hyperemic and porotic due to infection inflammation. The main advantage of the posterior instrumentation is that it can provide good fixation through posterior elements as the disease pathology is anterior. Posterior fixation also helps in correcting pre-existing kyphotic effectively. There are some studies who stated the same, like one is Lee Yang et al. he showed posterior instrumentation allows early mobilization, avoiding the complication of prolonged recumbency. Stability provided by the posterior fixation, particularly transpedicular fixation, protects the vertebral correction, and patients are able to return to normal activities within a short period of time. Bhauk and Garg, in a retrospective study of with thoracic and lumbar tuberculosis compared with the clinical and radiological functional outcome of anterior versus posterior debridement and stabilization, concluded that though the anterior approach is an equally good method for debridement and stabilization, kyphus correction is better with the posterior instrumentation, and the posterior approach is associated with the less morbidity and complication. GD Sundar Raj, in a prospective study of a patient with tuberculosis of the dorsal and dorsal lumbar spine, combined with the anterior posterior instrumentation, surgery concluded that adjuvant posterior stabilization allows early mobilization and rehabilitation. Lee et al. In a retrospective case series using the single-stage transpedicular decompression and posterior instrumentation of thoracic and thoracolumbar tuberculosis, concluded that it can be an alternative treatment method of less involved spinal tuberculosis, especially for patients in early phase of bone destruction or one with mild kyphosis. In other studies like Manish et al., in a case series of 50 patients of dorsal lumbar spine tuberculosis, stated that single-stage posterior decompression fixation showed good clinical and functional outcomes. And in Gilu et al., retrospective study of 37 patients showed good outcomes in terms of improved post-op WAS score, ODI score, Frankel grade, and correction of deformity. In conclusion, the procedure of the one-stage posterior debridement and transpedicular screw fixation and fusion without autogenous, with or without autogenous bone grafting is an effective and safe procedure for surgical treatment of the monosegmental thoracic and lumbar spine tuberculosis in adults. In our study, it is a case series of 30 patients. All were operated with single-stage posterior decompression and fixation. Preoperative mean ESR was 90, which improved to 45 at 6 months and 30 at 1 year follow-up. Preoperatively, WAS score was 7.9, which was improved to 1.1 at 6 months and 0.9 at 1 year follow-up. Preoperative mean kyphotic angle was 27.9, which was improved to 9.5 at 1 year follow-up. In terms of clinical improvement and neurological status, ODI score and Frankel growth showed significant post-operative improvement. Out of 30 patients, 28 patients showed sign of fusion during course of follow-up as per breathable fusion score, and average duration of AKT was found to be 11.9 months. On conclusion, posterior approach gives a reasonable access to the lateral and anterior aspect of the cord for an equally good decompression of the cord, and its less morbid approach and avoids problem associated with the thoracotomy and laparotomy. It facilitates early mobilization, avoids problem of prolonged recumbency, provides good functional outcome, and significantly better sagittal plane and kyphotic corrections. Posterior approach preferred because of its familiarity, its simplicity, and low complication rate. Majority of patients showed good signs of healing both clinically and radiologically on 12 months of AKT. Thank you.
Yeah, thanks, Dr. Tripathi. I think it was a good presentation, but just a small advice. The slides are too kind of crowded. So when you present your work, the slides have to have very less amount of written material so that somebody can read it out, and then the rest you can maybe add on your own. Now I take this opportunity to welcome Dr. Sumit Sural. He's a professor at Maulana Azad Medical College, and Dr. B.P. Sharma, Senior Consultant, Safdarjung Hospital. Thank you, sir. Thank you for sparing time. May I request Dr. Sumit Sural to please ask a few questions. Thank you.
Thank you, Dr. Harmesh. Actually, I thought the session was to start at 6 o'clock, but apparently it has started earlier.
No, that was 4 to 6, sir. Actually, it is in continuum. So it started at 4 o'clock. So half the papers were taken up by the earlier faculty.
But this topic was supposed to be at 6 to 8 session.
Because the earlier sessions finished early. That's right.
Due apologies, I have already finished 2 more papers from this session.
Okay.
3 papers are done and rest are remaining now.
No problem. So I just wanted to good study that you've done. So just wanted this thing. So basically, it's a posterior approach you're doing. That's the incision is posterior. What about the decompression? The decompression is because I missed that initial part. So could you just elaborate once again? What was the decompression? Was it transpedicular or was it anterolateral?
Sir, it was transpedicular, sir.
Transpedicular. Okay.
Yes.
So now you have showed in your study that the post-operative kyphotic angle you
Yes, sir.
you told about it at 1 year follow-up. So what is the
Yes, sir.
post-operative kyphotic angle, whether you could talk, mean or whatever, immediately after surgery, and what was it after 1 year follow-up?
Sir, immediately average was around 7 to 8 degrees, sir. But after 1 year follow-up, it was around 10 degree. So
Okay, so there was only a 3-degree change in your study.
yes, sir. Yes, sir.
Okay, so since you did a posterior transpedicular decompression,
Yes,
what
sir.
do you think that the outcomes was it different between in the cases where there was a liquid pus vis-a-vis it was dry inside?
Yes, sir. Patient with liquid pus was improved more, sir. I mean, deformity correction was good, and patients physically patient improved early, sir.
Okay, so do you have this thing difference? I mean, statistically.
No, sir. No, I didn't mention in the study, but I in the follow up I used to know this, sir.
Okay, and your inclusion criteria of these cases were at how many levels of tuberculosis?
I mean, sir, only single level, and dorsal or lumbar only 1 or 2 level in dorsal lumbar spine.
Single means usually it's a paradiscal. So
yes, sir.
Your inclusion criteria were paradiscal, or you were
Yes, sir.
having?
Yes, sir. Paradiscal.
So that means 2 levels, two bodies, and mostly thoracic and lumbar, right?
Yes, sir. Yes, sir.
Okay. So yeah. So anybody else wants to ask some question? Because
Dr.
I just wanted to
Aditya,
clarify.
I don't think any study can be complete without complications. You haven't mentioned about your complications in your study, have you?
Yeah,
yes, sir. I mentioned.
What were the major complications of your study?
Sir, major complication was surgical site infection, and
which kind of infection?
Yes.
It is already infected, I think.
Yes, sir. Three patient had a surgical site infection, and one of them, 2 patient was improved with conservative trial and antibiotics, and one patient we had to do debridement, sir.
Okay.
The question was, what type of organism was there in their infection?
Sir, sorry, sir, I don't. I mean.
Okay, fine. Dr. Sharma, Dr. BP Sharma, sir, could you please?
I just wanted to ask what type of fusion he has did, and fusion is really required or not?
Sorry, sir. Sorry. Hello.
Sir, एक बार repeat कर दीजिए. The audio was not very clear.
Are you fused the spine, and fusion of the spine is required in infected case or not?
Dr. Aditya, the question is whether you aimed at fusion.
Yes, sir.
In all the cases, and how successful you were?
Sir, in 8 patients there was we did fusion, and in them 6 patients were very successfully fused according to Bridwell grading, sir, and 2 patients didn't. So after 14-month MRI follow-up, there was no incomplete fusion was there, sir.
Okay.
So what was the method of fusion?
Sir, we put up an cage with bone graft and did an instrumentation, pedicle fixation, and then we put up a bone graft. We removed the infected area, and we inserted an PEEK cage with bone graft, and then we fixed it, sir.
So it was a anterior fusion.
Yes, sir.
So what happened to those patients where the fusion did not take place and the ones where there was infection? So what was the post-operative kyphotic angle after 1 year? Was there any breakage of instrumentation in any of these cases?
No, sir. Till now, we are taking the follow-up. I mean, sir, I'm in my residency. Till now, there is no breakage in the instrumentation, sir.
Okay. So you did mention about the Frankel's this thing, but what about the Asia scale? Because what were majority during the immediate or pre-op versus the final follow-up?
Sir, So I just included Frankel and ODI in my study.
I mean, the basic thing is Asia scale in logical, especially spine disease. I think the gold standard is always Asia scale first, rather than.
Yes, sir.
So, can you even now can you tell us generally like majority or which Asia scale and how much they improved? Because that gives the good this thing for us to understand.
Sorry, sir, I have to take.
So, Dr. Aditya, the learning is that you have to think when you present what all questions can be asked. You actually have to think yourself what all questions can be put up, and you should be thorough with your answers. So, anyhow, thank you so much for presenting. It was not a bad attempt. So, sir, Dr. Sumit, should we call the next candidate?
Yes, yes. Thank you so much, Dr.
Yes.
Dr. Yash. Dr. Yash. Dr.
Yes, sir.
Yash Mutha. Are you
Yes,
ready
sir.
for your presentation?
Yes, sir, I'm ready.
So Dr. Yash is going to present on cost-effective method of arthroscopic inside-out meniscus repair. Dr. Yash, please share your screen and start the presentation.
Okay, sir. Can I start?
Please start.
Hello.
We can see
Okay,
your
sir.
screen. Please start. Thank you.
Okay. Good afternoon, everyone. Thank you, everyone, for giving me this opportunity to present the paper on cost-effective method of arthroscopic inside-out meniscus repair. I would like to thank my guide and co-guide, Dr. Paresh Golwala and Dr. Aditya sir, for helping me out during this paper. Now, intro. Meniscal tears are one of the most frequently encountered and treated injuries around knee joint, with a bimodal age distribution in young active sports person, in elderly people, and with a relatively high annual cost spent on its treatment. Meniscal repair can be performed either in open or arthroscopically. At present, there are three main techniques for arthroscopic meniscal repair. First one is inside out, second one is outside in, and third one is all inside. Among them, the strongest repair accepted is in inside out technique, which was first described by Hennifer. Conventional arthroscopic meniscal repair technique requires meniscus stent, including meniscus repair needle and meniscal dart sheet, which might be expensive. These may cause financial burden and hence delay in surgery in some patients. We present a series of 10 cases of repair of bucket handle tear of meniscus with indigenous inside-out technique using urology needle instead of conventional meniscus repair set needle and Prolene 2. Materials and method. We present a series of 10 cases of meniscal tear treated at our setup, that is Dheeraj Hospital, SBKS Medical Institute and Research Center, by our indigenous method. After taking written and informed consent from patients under spinal anesthesia in supine position, diagnostic arthroscopy was performed and diagnosis of medial or lateral meniscus bucket handle tear with or without cruciate ligament injury was confirmed. After that, medial or lateral meniscus tear were reduced with probe first. Then a long urology needle, as shown in figure 1, was inserted percutaneously in such a way that tip of the needle engages with central part of the tear. Then needle with cannula was pushed out through the capsule and retrieved through the skin incision posteromedially or laterally, depending on meniscus which was involved. Then it was removed and keeping the cannula in situ, Prolene 2 was passed through the retrieved and was retrieved outside, as shown in figure 2. Similarly, needle with cannula was passed through the same incision and needle through peripheral part of the tear, pushed further out of the capsule and retrieved with skin incision posteriorly. As we can see in figure 3, Prolene is being retrieved posteriorly. Again, then needle was removed and through the cannula, Prolene 2 was passed out and now pulled out through the same posterior skin incision. The final meniscus repair consisted of at least 2 or 3 Prolene sutures from posteriorly to anteriorly. All sutures outside the capsule and stability of the repair was arthroscopically. Post-operatively, passive knee range of motion exercises were started from first day with non-weight bearing. After 1 month, that is after 4 weeks, active knee range of motions with partial weight bearing with brace was started, and after 1.5 months, full weight bearing was permitted. After that, patients were allowed to perform all his daily routine occupational activities. Patients were being regularly followed up at first 1 month, 2 months, and 3 months and evaluated under Knee Society score. Then in results, in a study of 10 patients, as you can see in this table, 80% of the patients were male, 20% were female, 70% had medial meniscus tear, whereas 30% has lateral meniscus tear. In mode of injury, 50% of the patients had encountered sports injury, 30% were associated with road traffic accidents, whereas 20% of patients had a trivial history of trivial trauma. Then discussion. There are two meniscus. Actually, in results, as per our Knee Society score, we have achieved 80% excellent and 20% good results. We did not had any form of complication in our study. Discussion. There are two meniscus. First one is medial and lateral meniscus. Medial meniscus is U-shaped and lateral meniscus is S-shaped, semilunar, hydrated, biphasic, fibrocartilaginous soft tissue structure in medial tibiofibular compartment of knee joint respectively. The morphology of this load-bearing complex structure determines its vital load-bearing, joint stability, joint congruity, increased joint contact area, joint contact stress, protection of articular cartilage, shock absorption, and limitation of extreme movement and proprioception. Meniscal injury of knee results in marked disability due to symptoms, clicking, and locking of knee. Patients can develop early osteoarthritis if meniscal injuries are not treated properly. For this reason, in today's era, repair surgery are of prime importance. Among meniscal repair, arthroscopic inside-out repair technique for meniscus is considered to be the best. Michael et al. Did the comparative study between 3 different techniques of meniscal repair. In his study, 30% underwent outside in, 35% has inside out, and 35% had all inside repair. Study suggested that inside out technique is the most preferred one since it provides a high rate of meniscal repair without prolonged operative intervention. Conventional arthroscopic meniscal repair would cost around $700 to $800 for ETA setup, whereas technique of arthroscopic meniscus repair with long urinary needle costed around approximately $30. Conclusion: arthroscopic inside-out method of meniscal repair is the most promising among achieving it by using a long urology needle and is suitable and cost-effective alternative commercially available meniscal repair needle and cannula set. Thank you.
Yeah, thank you, Yash, Dr. Yash, for reading.
Can you stop sharing your screen? Yeah. So, may I request Professor Sandeep Kumar to please ask few questions?
Dr. Yash,
yes, sir.
First of all, I'll tell you that whenever you are presenting a thesis or something, you have to keep minimum sentences in a slide. You just can't keep on reading it. Okay? Just for your next presentations, I would like to tell you.
Okay, thank you.
It has to be crisp and it should be imbibed by all the viewers and the audience. Okay? Keep 4 or 5 lines in a slide. Just don't fill up the slide. Okay? Second, it's a good idea which you have done it. So did you encounter any complication after your procedures? Only 10 cases you did. What was the most common complication which you encountered?
Sir, actually, our sample size was less. It consisted of 10 patients. In 8 patients, we have achieved excellent results at our follow-up. In only 2 patients, patients did complain of pain during walking, and only 1 patient had some kind of instability, which was patient was later treated conservatively at our only setup, and after further follow-up, he started doing all his daily activity.
Now you see,
Otherwise,
meniscal injuries are quite common, and the series is
yes,
too
sir.
small to comment anything. Okay. Now the cases where the injury is infrequent, or we find less number of cases, there to prove statistically we can take lesser amount of patients, means the less number of patients, which can be substantially concluded that okay, this study is good. So your case, the series is too small.
Okay.
What you can do, you can add on more cases to this, and then you can see the outcome.
Okay. Yes.
Dr. Sharma sir, Dr. BP Sharma sir.
Doctor, yes. As you said, in a bucket handle tear, you only attempted inside out, or you added some other all inside or outside anything?
No, sir. All patients in our study were treated with inside-out technique only. As I have already mentioned in some of theses, inside-out technique was much more effective than other two techniques. So we performed only inside-out technique.
Is there any difficulty in in addressing the anterior part tear of the meniscus or the posterior horn tear?
Yes, there were few, but we were as this means,
So out of 10 patients, 7 of them had ACL or PCL injury.
yes, sir.
So what did you do about that?
Sir, they were treated with means routine arthroscopy, means they were treated with same anterolateral and posterior portals only, sir.
No, they were reconstructed or
Yes.
not?
Sir, they were reconstructed, sir.
All the ACLs?
All the ACL, PCL were addressed. Sir, first meniscus were addressed. Later, after 1 week, we had treated ACL or PCL depending
After
upon
1 week?
which. Yes, sir.
Why?
First, we have.
Why not same?
In some patients, we have treated simultaneously, whereas we had to do comparative study also. That's why.
And how many months after injury, average, these patients were operated?
Sir, roughly around 3 months. Most of the patients visited our setup within 3 months of injury, and they were treated accordingly. There were no chronic patients. There were no chronic no chronic patients. So therefore, there might that might be a reason for this excellent outcome.
Dr. Sumit sir, please. So you have to unmute yourself. Sir, we can't hear you. Dr. Sumit?
Yes.
Yeah. Now we can hear you. Yeah.
So you had excellent results, but
Yes, sir.
every new procedure has got a learning curve. So what
Yes,
would you like to advise? What were the challenges that you faced during this procedure?
So actually, operating time was exceeded as compared to our normal intervention. We required around 40 to 45 minutes more than routine performed procedure. Also, during initial patient's follow-up, we had encounter some difficulties using this urology needle, but later on we got quite acquainted with this technique, and we performed it quite well.
So what was the step or the critical step where it was taking more than usual time?
Mostly during when this proline was being passed through needle, proline thread was getting wind up inside the tube.
So that is the usual problem, the toggling, and when you're passing
toggling,
in,
yes, sir.
so that
During
is the most
that is the most it was the most time consuming thing.
So from your experience that you've gained, how do you
yes,
what would you like to advise others how to overcome this?
Sir, actually it requires a lot of learning curve to do this, as our sample size was less. But because in our setup, poor patients usually come and they don't spend quite a lot of money for this. So we have devised this other technique for these patients only. There are few difficulties. We are quite means we are facing few challenges during this, but we have not concluded.
No, the question was about that critical step where when you're introducing the proline is you're having a challenge trying to put proline in. So what would you advise the others that how to improve upon the surgical step? When the time consuming at this critical step was there, any advice from your side?
So when the needle is within the cannula, it should be through the while retrieving the proline from posterior, medially or laterally. That is a key step, I think.
Okay, thank you.
Should we move on to the next speaker, chairperson?
Yes.
Yeah. Dr. Imran Shakil, are you ready with your presentation? Can I please request rest of the speakers to mute their mics?
Yes, sir. Hello, sir.
Dr. Imran,
Yes,
are you
sir.
ready?
Yes, sir.
So Dr. Imran is going to talk on radiological and clinical outcome of conservative management of thoracolumbar spinal tuberculosis in adults. This is going to be interesting because we just had a speaker talk about just the posterior fixation. Now we have a speaker talking about conservative management. It would be a very good comparison, kind of a review for all of us. So Dr. Imran, please share your screen and start the presentation.
Sir, is it visible, sir?
Yeah, we can see. Please start.
Yeah, sir, 1 second, please. My topic is radiological and clinical outcome of conservative management of thoracolumbar spinal tuberculosis in adult. ये हटा देना. Sir, please wait a second. I have a problem in my laptop.
It's moving, Dr. Imran, now. Take a deep breath and proceed. It's okay. Don't worry.
Sir, on introduction, sir, POTS disease continue to be the major health problem in developing and underdeveloped countries. Operative treatment of POTS disease is considered for the cases of severe spinal instability or progressive neurological symptom with evidence of cord compression or spinal deformity. It is unclear, however, as to when conservative management, rest, brace, ATT, physical therapy alone is the preferred treatment of POTS disease. Patients who exhibit both kyphotic deformity and minimal neurological impairment can be managed conservatively, which may be achieved by chemotherapy, antitubercular therapy. Alone, surgical indication in these patients are specific and few. Since the last decade, there is paucity of literature regarding the conservative management of thoracolumbar spinal tuberculosis, with increasing trend toward more and more surgical management. Some material and method. Present observational study was conducted in the Department of Orthopedic Surgery, Eras Lucknow Medical College Hospital in Lucknow, during the period between January 2018 and June 2019, after getting The approval from ethical committee of this patients were selected according to the following inclusion and exclusion criteria. The inclusion criteria were with the age of more than 18 years, stage 1, 2, 3 in Kumar's clinico-radiological classification, stage 1, 2 in Tully's classification. Exclusion criteria was patient with skip lesions, patient already on anti-tubercular therapy having side effects like deranged liver function to be excluded. Patients having immunodeficiency diseases like HIV and other comorbidities, patients having active pulmonary tuberculosis or other tuberculosis in body, patient not showing any clinical improvement on anti-tubercular therapy alone after 6 weeks, and those requiring definitive surgical intervention. Written and informed consent was taken from all the patients before including them in the study. Before starting the treatment, following a scoring system was used to assess the pre-treatment condition of the patient. Visual analog score for the back pain, OST disability index score for assessment of disability. Follow-up of all patients done at 1, 6, and 12 months. Patient to be recruited till 1 year and the course of ATT. Standard 4-drug initiation phase of isoniazid, rifampicin, pyrazinamide, ethambutol for the first 2 months. Continuation phase consists of HRE, isoniazid, rifampicin, and ethambutol for another 4 to 10 months was followed. Will be 12 months. Final follow-up was at 1 year. Relevant radiological evaluation, X-ray, number of vertebral body involvement, vertebral body and plate erosion, kyphotic angle was done. Magnetic resonance imaging, presence of tubercular abscess, vertebral body signal intensity change was done before the start of treatment and at the final follow-up. Blood investigation like complete blood count, erythrocyte sedimentation rate, CRP, liver function test was also conducted before starting the treatment and at subsequent patient visit. These are the clinical radiological classification and neurological deficit classification of Tully's. And now coming to observation and results. Total number of cases taken was 40. The mean age of cases enrolled for the study was 37.80 plus minus 11.35 years, while their mean BMI was 20.59 plus minus 2.04 kg per meter square. The study contains housewife in majority with 28 cases, while among male majority were farmer and laborer. Among the study cases, the most common clinical feature were local tenderness, which was seen in 36 cases, while the next to the most frequent feature was fever, found in 14 cases. Among the study cases, the most common lesion was paradiscal, which was seen in 35 cases, while posterior element was seen in 1 case. The hemoglobin of the cases enrolled in the study was 10.60 plus minus 1.68 gram per deciliter, while the mean total red blood cell count was 8,907 plus minus 1,789 million per cubic. The mean duration of the symptom among the cases was 3.542 plus minus 2.64 months. Wedging was found in 14 cases, compression fracture in 3 cases, and both in 1 cases. Among the study cases, the most common plain radiography finding was intravertebral disc space, which was seen in 36 cases, while the next most common was end plate irregularity, which was seen in 30 cases. Wedge collapse was found in 11 cases, compression fracture in 4 cases, and both in 5 cases. Among the study cases, the most common MRI finding was intervertebral disc space, which was seen in 35 cases, while the next most common finding was end plate irregularity, which was seen in 33 cases. On the basis of Kumar radiological classification, the stage 1 cases were 14, stage 2 and stage 3 cases were in the same proportion. On the basis of Tully's classification, the stage 0 cases were 17, stage 1 cases were 15, Stage 2 cases were 8. On the basis of ODI category changes, significant improvement was found after the treatment with the p-value of 0.00 less than 0.001. Before the treatment, 20% cases were belonging to the severe category, while only 35% were belonging to the minimal category. But at post-treatment, minimal proportion was increased to 85%, while severe was eliminated fully. The highly significant reduction in ESR was found after first visit, second visit, and final visit relative to the before treatment, which gives the p-value of less than 0.001 for each visit. The highly significant reduction in CRP found after first visit, second visit, and final visit relative to before treatment, with the p-value less than 0.001 for each visit. Now, the highly significant improvements were found in each of the ODI component, which includes pain, intensity, personal care, lifting, walking, sitting, standing, sleeping, sex life, social life, and traveling. The highly significant changes were found in ODI score was p-value of less than 0.001 and VAS scores. The highly significant changes were found in kyphotic angle. Now, the limitation of the study was the study only had 40 patients. A larger study group would have been required for a more definite conclusion. During this study at hospital, the hospital had not adopted the policy for biopsy followed by culture and sensitivity testing as routine for each patient before giving ATT. Thus, we really are in jeopardy as to how many of these patients were multi-drug resistant, whether they would behave the same as mycobacterial tuberculosis following treatment. Strict follow-up is must in these type of study because worsening of neurology can be diagnosed before hand in other surgery to be offered at the earliest. Now, my conclusion is that in this study, MRI gains the role of a pivoting stone in non-invasively diagnosing spinal tuberculosis as a gold standard investigation. The old regime of 18-month ATT is not valid nowadays. Just a meticulously applied 6 to 12 months of ATT is sufficient to achieve cure of thoracolumbar spinal tuberculosis. Judiciously applied conservative management may certainly give exceedingly good result. However, the crucial steps remain patient education and participation, which must be given utmost significance when the implementing non-operative treatment, especially in the presence of neurological deficit. Thank you.
An excellent presentation, Dr. Imran. I will request our chairpersons, Dr. Sumit, Dr. Ramesh, and Dr. Sharma to please ask questions accordingly. Dr. Sumit, sir, please, if you'll start the questions, please.
Thank you. So, yeah, of course, you need to improve upon your English and your this thing. Okay. So, you see, when you are presenting something like this in a study, your topic is radiological and clinical outcome. Okay, so you should focus upon if your topic is this, you should focus on this. You are going into details about RBC, this, that, MRI, as your take-home message. So I would like to know more about this radiological outcome. So what was your kyphotic angle measured on what basis? Which angle did you draw? What was the because they were all conservative. So what was the angle before the start of the anti-tubercular therapy? What was the change in the kyphotic angle during the course of the therapy at different periods? So let's start with the radiological angle because that is the first thing in your title.
Sir, firstly, when the patient came, we had taken the X-rays, DL spines X-rays. In these X-rays, we measures the Cobb's angle.
So it was the Cobb's angle that you were measuring?
Yes, sir.
So kyphotic angle, okay. So what was the pre-operative mean Cobb's angle? Usually we do the Dixon's or the Constant's angle. Anyway, what was the pre-operative, pre-antitubercular therapy Cobb's angle, and what was it after 6 months, let's say? That's where we are trying to select which of the cases do we need to operate for correction, for prevention of the progression of the kyphotic deformity, or is the surgical indication for the neurological deficit which has been already outlined in books.
So there were 11 patients with the wedge collapse fracture in this study, and 4 with the compression fracture. Sir, they have.
Yeah, you did mention. So what was their kyphotic angle before ATT and at 6 months of ATT or at 1 year of ATT? That's what we want to know. That's the outcome. No? That's your topic of today's presentation.
Yes. Sir, at the beginning of the study, when the patient came, sir, they have a kyphotic angle of around more than mean around 45 degree to 45 to 50 degree. Then, sir, after 6 months of these at 6 month follow up, sir, we had seen a clinical reduction in the Cobb's angle, which was around 40 degree, 35 to 40 degree. As we have given them brace for
yeah, are you sure about it? Because correction of kyphotic angle by bracing, what was the when did you correct this kyphotic angle? During the course of antitubercular therapy, was the patient admitted throughout? And was there any postural correction, or was it brace correction only? At what period was the brace applied? When you got a correction of 5 degrees?
Sir, when the patient came, we gave them a strict bed rest of around 1 month. When they are relieved with the pain and their clinical symptoms like fever, we make them walk. We make them walk with the crutches. Then and we apply the braces to the patient, and we give them precautions that they should stay in the bed for the more time, lying there.
So anyway, you should have calculated the kyphotic angle, because from what you are mentioning, 1 month of bed rest and then ambulation, and you are saying there is improvement of kyphotic angle needs to be relooked.
Dr. Imran, Dr. Sumit means to say that if your topic is this, then you should have prepared a proper slide giving us the exact values, because that is what your topic is about. Anyhow, Dr. Professor Sandeep, sir, will you like to?
Yeah, exactly. I totally agree with Dr. Sumit, sir, that for such cases, you have to show the X-rays. You have to see that what angle, was it better? Was it got worse? Now, I would like to ask you, how many patients while on ATT and in your study, you converted them into a surgical, required surgery ultimately? Were there any, or you just treated all of them conservatively?
We treated all of them conservatively, sir.
Because as per the standard protocol of a conservative treatment of a tuberculosis, especially in a thoracolumbar area, 1 month of rest is very, very less. The result which you are showing are little bit contradictory to what these things have already been done. So if you are giving a rest, it has to be given for 2 to 3 months. Because if you are start making them walk at 1 month, definitely the kyphosis is going to increase. Whatever you do, because this area is very, very critical area, thoracolumbar. The loading is too high in such areas. So I think you need to relook it, and then you have to again see your data, and again you have to go back to your patients and see exactly what is happening.
Okay, sir.
Thank you.
Thank you, sir.
I'd like to add again. So you see, in the previous speaker with an instrumented fusion, there is still subsidence which can occur, right? Even with an anterior cage. So without an instrumentation, it is not likely that there's going to be an improvement in the kyphotic angle if the patient is going to be ambulated at 1 month.
Okay.
Dr. Sharma, sir, you want to ask something?
I think paper needs to be relooked and reconsidered.
So same. So I think Dr. Chandip, we can ask the next presenter. Dr. Chandip, you're muted.
I'm sorry.
Yeah.
Next speaker is Dr. Kishan Patel. He's talking on ankle injuries gain importance because body weight is transmitted through it and locomotion depends on the stability of this joint. Dr. Kishan?
Yes, sir.
Please share your screen.
Yes, sir. Sir, is it visible or not?
No, Dr. Kishan, only we can hear your voice. We can't see your screen.
Hello. Slide.
We are not able to see your screen, Dr. Kishan.
Hello.
Shall we take Dr. Amit till in the meantime? You sort this out. Now we can.
Sure, sir.
Now, Dr. Kishan, we are able to see your screen now.
Okay, sir.
Choose the PowerPoint. You have to choose the PowerPoint.
Yeah. Okay. Sir, it is visible or not?
It's visible, beta, but it's a very small size. Am I the only one who's seeing the smaller size? Yeah, now this is better. Please start.
हाँ बस आ रहा हूँ ये मेरी ऑनलाइन क्लास चल रही है मेरी प्रेजेंटेशन है अभी मैं आ रहा हूँ डॉक्टर ने कहीं कर रहा हूँ हाँ ओके
Hello.
Please start, Dr. Kishan.
Okay. Good everyone. Good evening, everyone. My today's present topic is prospective study of functional outcome of open reduction and internal fixation of trimalleolar fractures. First of all, introduction. Ankle fractures constitutes a major proportion of injuries received at the orthopedic emergencies all over the world. Although the incidence of trimalleolar ankle fractures are comparatively less, nevertheless, these are disabling injuries if not managed appropriately. It is well described in the literature that ankle fractures involving posterior malleolar components tend to do clinically and functionally worse as compared to the others ankle. Recently, studies have stated that anatomical reduction and fixation of the posterior malleolus should be carried out in all cases of trimalleolar fracture, irrespective of its size and type, to obtain a good clinical and functional outcome. Ankle fractures involving the posterior malleolus are usually the result of a supination axial rotation or a pronation axial rotation form of injury. In majority of our cases, it's a typical Weber D or a Log-Hansen supination axial rotation form. According to the mechanism of such an injury, the posterior malleolus fragment is an avulsion fracture due to rupture of the posterior inferior tibiofibular ligament. It constitutes stage 3 of injury pattern to the ankle ring after involving the rupture of the anterior tibiofibular ligament and oblique fracture of the distal tibia, distal fibula.
एक प्रेजेंटेशन चल
The
रही
rupture है of the medial
मैं देखिए आपको आराम से करता हूँ
ligaments causing medial
Please,
malleolus
everyone
avulsion.
mute yourself. Everyone
With
mute
the
yourself except for the speaker.
Since
Dr.
the
Amit,
syndesmosis,
mute yourself.
since the syndesmosis of the ankle ring is stabilized mainly by the posterior inferior tibiofibular ligament, and the apex of the fibular fracture is mainly posterior or posterolateral in such injury, stabilization from the posterior side become paramount. In our study, we conducted a preoperative computed tomography scan in all our cases to better understand the fracture configuration and plan our fixation. The calculation of the fracture size is better on a sagittal CT of ankle joint rather than only a plain lateral X-ray. After anatomical reduction and fixation of the lateral malleolus, the posterior malleolus usually reduced by itself in majority of the acute cases due to ligamentotaxis by postero-inferior tibiofibular ligament. Open reduction and fixation of posterior malleolus from a posterior to anterior direction, thus making perfect sense to effectively manage these injuries. To achieve the same, the posterolateral approach has been well described in the literature, but still does not seems to be very popular among the orthopedic surgeons. Studies utilizing this approach is to fix such fractures are few in the number. The purpose of this study is to assess the functional outcome and result of surgical treatment of the trimalleolar fractures. The treatment option with open reduction and internal fixation technique available for trimalleolar fracture to attain a proper anatomical alignment and stability of ankle joint can lead to rewarding outcome for the patient and surgeon also. Material methods. My study is the prospective observational study of 30 patients with fresh trimalleolar ankle fracture who underwent surgery at the tertiary health setup in Surat, Gujarat from August 2019 to August 2020 was conducted. After institutional ethics, informed consent were obtained from all the participating patients, and then they were enrolled for the study. The inclusion criteria were age group more than 18 years of either sex with trimalleolar fracture, fracture of trimalleolar with or without associated fractures, confirmed by clinical examination, X-ray and CT scan. Patient who gives informed consent and billing for follow-up. The exclusion criteria were patient less than 18 years, patient who did not give informed consent for surgery, and patient unfit for surgery, and patient having ipsilateral lower limb fracture other than the trimal fracture. 30 patients fulfilling this criteria were included, consisting the 21 male and 9 females. Initial management was done in the orthopedic emergency area, which includes getting standard anteroposterior lateral radiograph of the ankle joints, the distal neurovascular status, and clinical signs to exclude compartment syndrome were assessed and documented. Patients with gross ankle dislocation were attempted to be reduced in emergency itself under sedation after prior consent from the patient and relative. Below knee plaster slabs were applied to immobilize the joint and analgesics were instituted. The limb were kept elevated to prevent excessive swelling. The fracture were classified based on Low-Jensen and Dennis Weber classification. After routine blood investigation and pre-anesthetic clearance, patients were posted for surgery. An ankle CT scan was conducted in all cases as a part of preoperative planning. And preoperatively, intravenous antibiotic was administered 30 minutes prior to the skin incision in the operating room after prior antibiotic sensitivity testing. Surgical technique under appropriate anesthesia in lateral or prone position for lateral and posterior malleolus fixation, and then supine position for the medial malleolus fixation. Then pneumatic tourniquet was applied. Average timing of the surgery half to 2 hours. Posterolateral approach was used for the lateral and posterior malleolus fixation, and anteromedial medial approach was used for the medial malleolus fixation. For lateral malleolus fixation, in our studies, there is in 24 cases, lateral mal fixed with 1/3 tibial plate, and in 6 cases with reconstructive plate. For medial malleolus, in 14 cases, the tension band binding was done, and in 16 cases, fixations were done with 4M CC screw. For posterior malleolus, in 7 cases, it was fixed with 4M CC screw. In 11 cases with buttress plate, and in 12 cases with reconstructive plate. The patient was subsequently discharged after dressing changes at 3 to 4 post-operative days. A below knee plaster was maintained until 2 weeks post-operatively. Stitch removal and application of the BK cast was done at the 2 weeks. A strict non-weight bearing and ankle range of motion exercise protocol was maintained until 6 weeks post-operatively. Follow-up at 6 weeks was done when radiograph of the ankle joint were repeated and partial weight bearing with the help of the walking aids was initiated. Regular monthly follow-up were conducted. Full weight bearing was started once the clinical and radiological union was achieved. Ankle score according to the Bird and Jackson score was documented in all cases. In results, there is 30 adults patients with an average age of the 45.7 years. Age range between the 21 to 62 years were followed up prospectively in our case series, of which 21 were males and 9 were females. The most common mode of injury was road traffic accident. Since we performed the surgery in 2 positions, the average duration of surgery was 1.5 to 2 hours. The average time to union and full weight bearing was 12.8 weeks, range between 10 to 16 weeks. The average percentage of the restoration of range of motion as compared to the contralateral ankle at the time of union was 19.8% of dorsiflexion, 95% of plantar flexion, 86% of inversion, and 87% of eversion. And excellent results were achieved in 17 patients, around 56.67%, and good in 8 patients, fair in 3 and poor in 2 patients according to the Bird-Jackson scoring system. No complication related to soft tissue healing, pain, and hardware impingement or breakage were encountered. Discussion increased the knowledge about the normal and post-traumatic anatomy and function of the ankle joint has lead to demand for exact reduction and rigid fixation of the ankle fractures. Prompt operative treatment of displaced trimalleolar fractures decreased the morbidity and improved the functional outcome. We in our study followed a protocol to anatomically reduce and fix the posterior malleolus fragment in all our cases. This method is well supported in the recent literature too. In all our cases, after fixation of the lateral malleolus, we performed a posterior loading test intraoperatively to see for the stability of the ankle joint. Good clinical and functional outcome was reported in cases with the fixation of the lateral malleolus by the application of the plate on the posterior surface. Many biomechanical studies have also recognized the advantage of the posterior plating of fibula as compared to plating over the lateral surface. However, one study has found to the no significant difference. We observed that the apex of the fibular fracture was posterior and the posterolateral in the majority of such injury, and we believe that the application of the plate over the fracture apex is biomechanically much superior. We believe that posterior malleolus fracture by buttress plate and interfragmentary screw from posterior to anterior direction played a significant role in obtaining good outcome. Recognizing these fractures having a vertical shear nature, providing strong fixation with the help of the buttress plate become pivotal. Ankle joint being a weight-bearing axial loaded joint demands rigid fixation for early weight bearing. Good posterior malleolus reduction and fixation should be obtained in trimalleolar fracture irrespective of its size and type. Stable fixation of posterior malleolus by plate is also has an advantage of making the syndesmosis extremely stable. Additional syndesmotic screw application thus become unnecessary. Now some studies are compared with my studies. D'Souza et al. Conducted study on 150 trimal fractures treated by open reduction and stable fixation using low ASIF method, obtained 90% good results. Barris et al. Conducted study on 44 patients with trimal ankle fracture. There was good to excellent result in 74% patient. And observation in this study support the contention of the Abel et al. Study that lateral malleolus is the key to anatomical reduction of trimal fracture because the displacement of the talus faithfully followed that of the lateral malleolus. A poor reduction of the distal part of the fibula would result in persistent lateral displacement or residual shortening. Adequate preoperative imaging, thorough understanding of the fracture anatomy and biomechanics, and adequate visualization via proper exposure and stable fixation of all the 3 components of the trimal fracture play a key role for good clinical and functional outcome in such injuries. More severe injuries, compound fractures, and severely osteoporotic fracture were followed by least satisfactory results. Thank you.
A very extensive presentation. Our chairpersons have already emphasized again and again. Maybe everybody needs to start making it crisper. I'll request Dr. BP Sharma, one of our chairpersons, to start the questions. Sir, can you just take the lead here, please?
Just wanted to ask whether all posterior malleus needs fixation or some posterior malleus treated conservatively also.
My study is on only operative management, not a conservative including. So I study all the trimalleolar fracture with operative management only.
Okay. Dr. Harmesh Kapoor, we want to ask something.
Sorry. So, how did you decide whether to fix the posterior malleolus by a screw or a plate? How did you really decide? Or it was just a whatever came to your mind? Was there any criteria to decide whether to fix it with screws or with plate?
It is decided on the fracture fragments. If the fragments, posterior malleolar fragments were enough to is short enough, if there is no, it is not fixed by the screw, then it was buttressed by the plate.
So if it is a small fragment, then it is better to plate, right?
Yes,
yeah, fine. And what about the lateral malleolus? Again, you have put sometimes posterior plate and sometimes lateral plate.
So in my cases, there is a trimalleolar fracture. Most of injuries are the supination external rotation or pronation external rotation. In this type of injury, the lateral malleolus fractures are most of the time there is oblique, spiral oblique fracture.
Any complication of putting a posterior plate?
No, sir.
What about the peroneal tendon irritation?
Easy to approachable in a single incision, posterior mal and lateral mal in a posterolateral approach.
Yeah, what about the peroneal tendon irritation?
Sir, irritation.
Okay. So, Dr. Sumit, sir, please, if you want to ask something.
Yeah, so it would have been better if you had shown some radiographs, and it would be better if you had actually classified your the patients into different categories, that which ones were the ones requiring plate, which one requiring screw, because the entire presentation I was trying to really find out what exactly was done, and it appeared to me as if all were plated. But then when Dr. Harmesh asked a question, then he said some were screws, some were plated. So, when you're putting a presentation, we should know, and with some x-rays. What would you say would be the challenging steps during this procedure, intraoperative challenging steps?
Stopping intraoperative, so reduction. The main things are reduction. So first, we fix the lateral mal. There is easy to reduce the posterior mal.
So first you reduce the.
Sir, in sometimes if there is. First we reduce the. First we fix the lateral malleolus. After that, we buttress or after that we posterior mal fixation done with buttress plate or a CC screw.
So first you would have got the reduction of the posterior malleolus, and then you fix the lateral malleolus. Or were you able to reduce the posterior malleolus if it was not reduced and you had fixed the lateral malleolus?
So you don't have to fix the lateral malleolus, you have to only preliminary fixation has to be done, not the final plating. And then you have to fix the posterior malleolus first, then come back to the lateral malleolus and do the final fixation. That is the right way.
Exactly. So did you use the Gatelier and Chastang approach in any of your case? Or
Sorry, sir?
were you using the Gatelier Chastang approach also, or just without?
No, just posterolateral approach.
Just posterolateral.
Just
Okay. Okay, you should show some radiographs. Then only.
And also you overshoot your time quite a bit. You were supposed to finish it in 6 minutes and you took around 10 minutes. So here we allowed it, but in most of the big conferences you will not be allowed. So you will be leaving most of your important slides if you have to give only 6 minutes. So Professor Sandeep sir, your inputs?
Yeah, I think the study was good. The only problem is that there is no comparative study. There is nothing to compare with. Now, if you are doing a single study and irrespective of the size of the malleolus, then this study doesn't mean anything actually. So it has to be either you have to classify according to the size of the trimalleolar fracture. How big is it? Is it 10%? Is it 20%? Is it 30%? And are you going to operate even if there's a small, a very, very small flake? Still, are you going to fix it? Or are you going to leave it? So there's no clarity regarding that, because just a posterior malleolus fracture doesn't solve the problem. Yes, that is true. According to the literature, nowadays it is recommended that we should fix the posterior malleolus. Then you have to see the per-op stability of the ankle. It's not that you are just going to fix all the fractures of the posterior malleolus, irrespective of the size. So the on table, the stability of the ankle plays a very important role, because you see, you are going to increase the time also. You have to change the position of the patient also. So there are so many factors. And then such fractures are usually quite swollen up, and they might lead into the compartment. If you're going to put so much of a metal, irrespective of the size of the posterior malleolus, I think it's not a very wise idea. But yes, we have to check the stability of the ankle. And if really required, then definitely we should fix it. There is no confusion in that. But then there has to be some criteria that how we have to go about it.
So, Dr. Chandip, if there are no questions, maybe we can call upon the next.
We'll move on to the next speaker, Dr. Amit Lakhani. Dr. Amit Lakhani, are you ready?
To hear me?
Dr. Amit, we can hear you. Can you please start sharing your screen? Dr. Amit, your voice has a lot of echo. Can you just try and improve your sound quality a bit? Can I just request the other speakers to please mute your mics? It will be really nice. Dr. Amit, can you hear me? Dr. Amit, we can see your screen, but we can't hear you.
Dr. Kishan, mute yourself. Dr. Kishan Patel, could you mute yourself?
Any of the hosts, Dr. Amit, you are sharing a video of the YouTube. You have to share your PPT. Yeah, this is what you need to share. Click on it. This is the PDF. You can make it whole screen, or you can share your PPT.
Sir, actually, I have just converted the PPTs as the PDF.
So make it whole screen, and you can talk on that. We don't have a problem. Just close the side window.
Sir, actually, according to the DOACON requirement, I just converted all my PPT slides in the form of PDF format.
Amit, we are okay with it. That is not a problem. Just click on the side and make it whole screen if you can. And we will go by this also. That is also not a problem. If the chairpersons are okay, can we proceed, sir? Okay, Amit, please start. Please start.
Good evening, everyone. Sir, I am just making my small presentation about the e-rehabilitation solution for rotator cuff syndrome in this time. Basically, sir, the idea started when we started our OPDs in the COVID pandemic time, and we were receiving a lot of patients of the rotator cuff syndrome, basically shoulder pain patient, which have disease affecting like which have
Dr. Kishan.
problems like tendinitis,
Excuse me,
bursitis,
Dr. Amit,
rotator
just a
cuff
minute.
region.
Dr. Kishan Patel, please mute yourself. Dr. Kishan Patel.
डॉक्टर बलजिंदर, आप को होस्ट हैं, आप भी म्यूट कर सकते हैं उसको.
And also, Dr. Amit, if it's maybe you're having your two electronic devices in the same room. If you're having your phone and laptop, please switch one of them off.
Doctor, hello.
Dr. Amit, it seems you have more than one electronic device in the room. If you have your phone and your laptop both on, please switch off your phone or keep it at least 3 feet away from your laptop.
Okay, sir. Hello.
Yeah. Now, can you please start your presentation?
Good evening, sir. Sir, I am just giving my very small presentation on the e-rehabilitation solution for the rotator cuff syndrome in the COVID-19 pandemic era. Sir, rotator cuff syndrome refer to a disease which affect the rotator cuff in the shoulder, which include tendinitis, bursitis, rotator cuff tears, and impingement syndrome. And we get a lot number of patients in our OPD which have the problem in the form of shoulder pain and inability to give the full range of movement, restricted movement. And these patients vary from, sir, from young patient to very old age persons. Sir, we all know that in the case of rotator cuff syndrome, the main treatment remains the physiotherapy. And in the COVID-19 pandemic, we were advising patient the physiotherapy initially, just doing the home exercises, but they were not able to get the exercises done in a proper way. So we give them telephonic consultation, and everyone was saying that we are not happy with this physiotherapy at home. So sir, we discussed with our physiotherapy department in our medical college, and we decided that we will start a thing that maybe it's a new concept for us because sir, my medical college is in a very rural area of Himachal. It's in the Solan district. So we decided that we will try to give we will try to start e-rehabilitation. This will help not only to prevent the cross contamination, as sir we know, because in the COVID-19 pandemic, the physiotherapy units which were in the private centers, they were all closed, and the patients just don't want to visit the physiotherapy center. They don't want to come to OPD on the routine basis. So we decided to start this thing, that is the e-rehabilitation, and we found this the e-rehabilitation was very good for patients as well as for the doctors, as we were very scared of this COVID-19 cross infection. So the usage of mobile app for health benefit is not new, but in our country it's a very new concept. Poor financial condition, most of the patients, they don't have phones, and network coverage, especially in our area, is very poor. But we tried to analyze that lots of patients were coming with the smartphones, and if they were not the smartphone users, their attendants, their children's, their grandchildren's were all the smartphone users. So sir, we reviewed this e-rehabilitation. Sir, we collected the data. We did an observational study, sir, with out of 506 patients which we seen in the 4 months in our medical college, 135 patients were of rotator cuff pathology, which have been problem in the form of shoulder pain and the shoulder range of motion. Sir, there are various rehabilitation apps available for the shoulder exercises, and with the help of our physiotherapy team, we divided these apps into two types. One app there was one group of apps, they were more beneficial for the frozen shoulder, and one app was for the pain symptoms in the shoulder. So we divided these apps into two types, and in the OPD, sir, we divided our patient into two types. One which have the main complaint was the restriction of movement, means that was a frozen shoulder, and one patient was there which have main complaints with the pain, means they're having pain but in the terminal range of motion, and we classified them as the rotator cuff syndrome. And in each group, sir, we divided and we asked them to download these apps and asked them to exercise at home. Sir, we telephonically assess these patients 1 a week for 4 weeks. And after 4 weeks, sir, we collected the data and we see, sir, a tremendous benefit in all the patient. Means initially we were all thinking ki in a rural area in the Solent district we will not able to counsel the patient for using the e-rehabilitation app, but we counseled them, so they were all doing great. We analyzed our result on the behalf of VAS score telephonically. On video calls, we assessed the range of motions and various question area with the help of DAS score. So this study was done with the help of physiotherapy team in my department, and we, sir, face certain difficulty when certain patient complained us that all the form apps were in the English. There was no app available in the Hindi or their local language, that is the Pahari. So we are planning, we have started doing some work in the form of we are developing our own app for the shoulder exercises in our Hindi language as well as certain Pahari conversation out. And so internet connectivity and lack of skill using the smartphone is also was one of the very big issue, because certain patients, they were using the phone of their grandchildren or their parents and they were available only in the evening, and in certain areas internet connectivity was the issue. But sir, we analyzed the patients were happy with the apps, because these apps were come with a planner. They will be just tracking their progress and they were just tell them even to do the exercises. So sir, we find this e-rehabilitation apps were very good in the COVID-19 pandemic, and we advise or we suggest that these apps can be beneficial for the rotator cuff syndrome, not even, but in the case of post-operative TKR, post-operative spine surgeries, and that's it, sir. And we are working our best to make a new app in our own language, sir. Thank you, sir.
Thank you, Dr. Amit. Very interesting presentation and a very interesting topic. Can you please stop sharing your screen?
Yes, sir.
It's very discerning to see your own photograph on the screen.
Yes, yes, sir.
It's up to the times, though I think the presentation should have some more information. I will request Dr. Harmesh, who's one of the most tech-savvy persons I know in the orthopedic circles, to ask you the first question.
Yeah, my only question is, what was the, paper about? I couldn't really, it's okay, I know in pandemic, everybody is actually doing Google and finding out their own exercises. What were the papers there to study? What really, paper means you have to fix a goal or you have to hypothesis something, and then you have to prove or disprove at the end of your study, whether that hypothesis stood true or not. So I couldn't really come to the idea is okay, the message is okay, that we should not call the patient and we should not crowd our OPDs and everything is fine. But what was the purpose of the study and what was the end result of the study? This I couldn't make out in the whole thing. So this was
so the main, our aim was that every one of us just was not convinced that in a rural area like this we can have this app and we can do some good work. But when we analyze the result, that it was a good one. I think, sir, just the purpose of this presentation was that the e-rehab have, this is also a very good option in this time in a rural area. So every medical,
it's a message. Study is properly designed. You
it's
have
a
to,
yes,
have some end results. You have to have some goals, and then you have to tell us at the end of the study that this was the follow-up and this is what the result is. But I don't see,
yes,
I
sir.
think more of a message, I think. I don't know, Dr. Sumit, what do you say about it?
Yeah. So yes, Dr. Harmesh. So one is that congratulations, you're doing something new. Initiative has been taken in a rural area. Okay.
Yes.
So
Thank you,
that
sir.
is good. But as far as a study is concerned, then either you are doing a comparative study with the app and without the app, or it's just basically it's a descriptive study that you've done, that you have made an app. So you should have shown a little bit about the app also, right? And how it is benefited, because you have calculated a few scores, dash score and all that, that you did mention. But really the study has not been designed well in that way, like Dr. Harmesh.
Sir, can you give sir some idea that how can we elaborate in this this study into a good study? We want to do something with the help of apps in this time in the rotator cuff syndrome, sir.
Can I request for this
beyond the scope of
conversation
the-
to carry on at a personal level, because we have three,
Okay, sir. Thank you,
three or
sir.
four
Thank you.
more presentations.
Thank you, sir. Thank you.
Though I would seriously, strongly suggest that you get in touch with Dr. Sumit, Professor Sumit actually, because Dr. Harmesh's point is well taken, that it should have an aim and objective, and then you proceed accordingly.
Okay, sir.
Just a housekeeping announcement for the rest of the speakers. The time is 7:25. We have 3 confirmed speakers. So please suggest that we maintain our 6 to 7 minutes timeline. If the chairpersons allow, we will be slightly strict about it. So next speaker is Dr. Nrutik Patel. He's talking on a prospective study regarding outcome of idiopathic clubfoot patients treated with Ponseti method. Dr. Nrutik Patel. Dr. Nrutik Patel, are you there? Dr. Patel, I can see you on the list.
Hello.
Dr. Patel, you are muted. Please unmute
Yes,
yourself.
sir. Hello. Good evening, sir.
Yeah, please start sharing your screen.
Sir, screen is visible on.
Yeah, we can see it. Please start your presentation.
Good evening, everyone. Sir, my today presentation is on a prospective study regarding outcome of idiopathic clubfoot patient treated with the Ponseti method. First is the introduction. The CTV is the pathology which is known since the ancient time. Meanwhile, the first treatment of the deformity dates approximately 1000 before Christ in India. Then Hippocrates around 400 BC described and begin to treat treatment. The result over 95 children born with the clubfoot can have the full functional fit in the gentle treatment pioneered by the Dr. Ignacio Ponseti.
Hello, sir.
In last 2 decades,
Sir, I have joined Zoom, sir. Still, some speakers are giving the presentation.
In last 2 decades, benefits of the Ponseti method is in early treatment of clubfoot deformity have been highlighted. The paper consists of the study of result idiopathic foot treated with conservative by the Ponseti method. It reveals increased awareness among the patients that the deformity can be fully corrected, leading to early consultation and regular follow-up. The major etiology is of the clubfoot is the mainly idiopathic or the non-idiopathic clubfoot. Idiopathic clubfoot is when the deformity is not associated with any other deformity and abnormality in the body. It is the most common type, and the non-idiopathic is the associated with the local manifestation of the some systemic musculoskeletal disorder. In the idiopathic clubfoot, many theories have been put forward to explain the etiology. They are followed mechanical factor, germplasmic defect, arrest embryonal development, hereditary neuromuscular defect, teratogenic theory, bone anomaly, failure to muscle development, congenital dislocation of nerves on talus, and circulatory temporary or permanent breakdown of the circulation leading to fibrosis of the tissue. On the basis of the non-idiopathic clubfoot, there are the many symptoms: syndrome, erythrolysis multiple congenita, Neil patella syndrome, congenital constriction vein, neurological disorder, lead poisoning, dystrophic Var's vision, Gordon syndrome, Moebius syndrome, Larsen syndrome, Smith and Lemprieres syndrome, Perry-Robertson syndrome. On the pathology of the clubfoot, in the clinical pathology, there is a displacement of the navicular and the calcaneus, produce an inverted or varus input, and the entire complex rest in the equinus. Contracture of the soft tissue, ligament, joint capsule, and the tendon. Maintenance is pathological malalignment of the joint, described as a equinovarus. The mid-tarsal subluxation, the navicular and cuboid displaced medially with the plantar and medial rotation of the calcaneus. The foot is plantar flexed at the ankle. Input is inverted at the subtalar joint, and midfoot and forefoot are adducted, inverted, and equinus position. This deformity is the result of medial and plantar displacement and the medial rotation of the talocalcaneus.
Mute yourself, please. Allow the speaker to speak. Everyone mute yourself. Everyone mute yourself.
Component of the deformity is the equinus, varus, adduction, cavus, and the internal tibial torsion. In equinus, the foot is fixed in the plantar flex position. Equinus deformity is the composite of the ankle joint equinus, inversion of talocalcaneal navicular complex, and the plantar flexion of the forefoot. In varus, the hindfoot is rotated inward. This occurs primarily in the talocalcaneal navicular joint, and the whole tarsus, with exception of talus, is rotated inward with respect to lower leg. In adduction, the foot is rotated inward. The medial displacement occurs at the talonavicular and the anterior subtalar joint. In addition, some medial deviation occurs at the tarsometallus area also. In cavus, the forefoot plantar flexion causes a cavus deformity and contributes to the composite education. And also there is an internal tibial torsion. Yeah, on the articular malalignment, there is a lateral rotation of the talar body around the vertical axis. Navicular displays medially and upward. Abnormal calcaneal movement take place in the 3-dimension horizontal, coronal, and sagittal. Cuboid is translated medially in relation to anterior facet of the calcaneus, which is inclined inward. Classification of the CTV is mainly based on the Pirani score and DiMaglio's classification. We consider both scoring system in our study. And the detail of the Ponseti technique. In the Ponseti, there is mostly the casting maneuver and followed by the tenotomy procedure. In the firstly, there is the reduction of the cavus, manipulation, stabilization of the talus, manipulation of the foot, second, third, fourth cast, and the cast application, molding and removal, and the lastly is the cast removal. Tenotomy. Tenotomy is the major decision point in the management is determined where the sufficient correction has been obtained to perform the percutaneous treatment to gain dorsiflexion and to complete the treatment. This point is reached when the anterior calcaneus is abducted from underneath the talus. This abduction allowed to foot the safely dorsiflex without crushing the talus between calcaneus and tibia. If the adequacy of the abduction is uncertain, apply another cast or two to be certain. We use the Steinbeck splint in our study patients for the post-tenotomy correction splint. Aims and objective of the study is to assess the correction of idiopathic clubfoot by Ponseti and to identify the complication associated with the Ponseti. In the complication associated with the cast maneuver, splint process, and there is the tenotomy complication. In the methodology, source of the data are all patients below 2 years of the age with the idiopathic clubfoot in Government Medical College Surat between February 2019 and to the February 2020 were treated by the Ponseti method were subject in the study. Inclusion criteria: all children with the idiopathic clubfoot below the age of 2 years included, and the children greater than 2 years or any other congenital abnormality were excluded. Their result is the sex distribution is the around the male 68% was the male and the 32% were the female. In the side involvement, there is the bilateral in the 36%, right on the 39%, and the left on the 25%. In the age distribution, 0 to 6 months include the 59%, 26% includes 6 to 12 months, and the 15% of around 1 to 2 years. Tenotomy required in 78%, and doesn't require tenotomy in the 22%. And the cast related complication is included in the 21%, which include the consequence cast tenotomy complication. We use the DiMaglio score and the versus number of foot and the average Pirani score at the different age group, and the average number of cast as the age increase, the average number of cast is also increased due to some rigidity of the clubfoot. In present study, we treated the 100% with the idiopathic clubfoot by Ponseti method of the correction of scissor manipulation casting. Out of 100%, 59% presented with the between 0 to 6 months, 26 between 6 to 12 months, and 15 between 1 to 2 years. Among the 100%, 64 were unilateral and 36 were bilateral. And the average number of casts were 5.5 in 0 to 6 months, 8.53 in the 6 to 12 months, and 8.484 in 1 to 2 years. The mean number of casts required was 7.5. Tenotomy required in 78%. By using the 6-point pyramid score system, we calculate the average pyramid score for the age group 0 to 6 months is 4.03, 6 to 1 year is 4.36, and 1 to 2 year is 4.40. The average number of pyramid score also increased as the age increased. In the 7% allergic skin reaction occur, 6% had the cast loosening, 5% had the tight cast, and the 3% developed pressure sore, and 5% had the relapse. Conclusion is the CTV is the most common deformity of the foot, and the positive method is the safe, effective for the treatment of the CTV in up to the 6 years of age. This technique also used in the relapse. This method reduces the need of extensive corrective surgery, which is associated with the complication. Although the foot looks better after surgery, it is stiff, weak, and often painful. Often in after adolescence, pain increase and the often become crippling. Positive method economic, easy on baby. When well implemented, it will greatly decrease the number of the clubfoot cripples. We have seen that the correction started earlier required less number of casts. We conclude that the positive method is the easy, effective, efficient, economic mode of management of the congenital clubfoot. Congenital clubfoot is the commonest deformity. Idiopathic clubfoot is a common deformity around the 80% of the case. Treatment of the severe clubfoot has been challenged over the years with the poor result. The positive method of the treatment has changed the face of orthopedic, and the assessment of this method in treatment of idiopathic clubfoot was the objective of this study. The results show that this method is effective in the treatment of severe, recurrent, and complex deformity. Many complications can be anticipated and prevented or treated with the same method. Our results are comparable with the result worldwide. The method should be recommended method in the correction of idiopathic clubfoot as well as the first mode of the Thank you very much.
Thank you, Dr. Nrutik, for the presentation.
Yes, sir. Thank you.
No, I will just request Professor Sumit to please ask a few questions.
Yeah, thank you. So actually, you're lucky, Dr. Patel, that the Delhi Orthopedic Association is very generous that in spite of a warning of 6 minutes, allowed you to
speak for 9 minutes.
Your entire thesis. The first part of his review of literature itself was too extensive.
Yes,
but
sir.
Message. Is there any new message from your study? That is what, because this is now an established technique. It is being done all over the world, especially even in our country. So what message do you want to give through your study?
So
is there a follow-up? Is there any recurrence? Is there any new message?
So in our study, in our institution, the patient mostly from the rural area, they are mostly lost the follow-up. We advise them to follow up after a week, but many patients follow after the 2 weeks or 3 weeks. So many number of the casts are very increasing due to the loss of the follow-up, and the parents are not educated enough to wear them the splint. So we are not able to correct them efficiently with the cast and splint only. We have to ridiculous enough to strict on the basis of the follow.
So Dr. Patel, if your study would have highlighted this, that how many percentage of cases frequented the OPD at the interval of 1 week or 2 weeks or 1 month because they were neglected, they were from far rural areas, then we would have had a better assessment of what you're trying to tell.
Yes,
right?
Sir.
Instead of giving the entire theory, you should have highlighted that part, right?
Yes,
so if the patients are not coming for 2-week follow-up, what is the outcome? If they're coming after 1 month of follow-up, what is the outcome? If the cast change, the time between the cast change is more than 2 weeks, more than 3 weeks. So that sort of an assessment you should have done.
Yes, sir.
Yeah.
Professor Harmesh, any questions? Dr. Harmesh.
Yeah, if I may say, it's right, Doctor. I agree with Dr. Sumit. So it's an established mode of treatment for last 30 years. So
Yes.
study is basically to say that, okay, this established thing needs to be changed, or we have tried something new, or some outcome or some study parameters have changed. So it's a very, very standard way. Everybody knows that Ponseti method is there. So I mean, just doing a study again on the same subject, I don't see it as a very innovative thing and something to be very kind of praiseworthy. So it's like saying that 80 years old neck femur, we are doing bipolar and we're doing a study. So it's a standard treatment. So the study has to have something new in it. What is objective? What is we want to prove? This is a proven fact.
Yes, sir.
This is all what I have to say.
Yes, sir. Thank you, sir.
So if the chairpersons allow, should we move on to the next speaker?
Yes.
Dr. Anil is the next speaker. Dr. Anil, are you ready?
Dr. BP Sharma wants to say something.
Yes,
Yes, sir.
I also wanted to say, you are already told.
Yes, sir.
So should we move on to the next speaker, Professor Sharma?
Yes, yes.
Dr. Anil, are you ready? Dr. Anil, don't send a message. Please speak and share your screen.
Yes, sir. I'm ready, sir.
So please share your screen. Dr. Anil will be speaking on comparative study of functional outcome of distal tibia fracture using MIPO versus nailing. Dr. Anil, you will get a first warning at 6 minutes, and 6 minutes 30 seconds we will close the screen, or we will tell you to stop. Okay. Do I have the approval of the chairpersons? I'm sorry.
You are the boss.
I am not the boss. मेरे को already डांट पिट चुकी है.
It's a little unfair for the last person because you were.
No, he's the second last person, sir. We will allow them to speak, but just a suggestion. Let's try and be more crisper. Let's learn from. See, we all have done this. I have done this. I have gotten scoldings as well. So let's try and be slightly. Let's learn from other people's experience.
Yeah, and in international conferences, the screen blacks out. That's it.
Okay, Dr. Anil.
Yes, sir. May I start, sir?
Yes, please.
Okay. Good evening, respected teachers.
There is some echo at your end. Again, maybe you have a phone on with the or something is there.
Nothing is there, sir.
Sir, I think he's just in a small room. He's just in a small room. So
yes,
be careful. Yeah.
Good evening, respected teachers. Today I'm going to speak on topic a comparative study of functional recovery outcomes of distal tibia extra-articular fractures treated with intramedullary nailings and MIPO, a study done in a government tertiary care hospitals in Fal. Introductions. Tibia is one of the most commonly fractured long bones of the body. It is primarily located within a square based on the white of the distal tibia. Treatment of distal tibia fracture is challenging because of its unique anatomical characteristic of subcutaneous location with precarious blood supply and proximity to the ankle joints. Minimal invasive plate osteosynthesis and intermediate nailings are the two well accepted and effective methods of the treatments for distal tibia fractures. Aims and objectives. To compare the functional recovery outcome of the patient with extra-articular fracture. 438 treated with intermediate nailings and plate osteosynthesis using MIPO techniques. Material methods is an RCT trials study for 2 years, is a hospital-based study in the Department of Orthopedics, Jarims, Imphal, and all adult patients of age more than 18 years old with close distal tibia fracture admitted in Jarims Orthopedic Department, Imphal. Sample size is 16. The inclusion criteria are age more than 18-year-olds. It should be extracardiac fractures, patients who are medically fit for surgeries, and the exclusion criteria are pathological fractures, all open fractures, patients who are medically unfit, fracture extending to the ankle joints, and patients who are unwilling for surgeries. And the surgical steps are first, the MIPOs are done in the anteromedial approach. Anteromedial curve incisions is given at the distal end. Subcutaneous tunneling formation is done with the help of peristral support, and the proximal incision is given. After that, the plate inserted from proximal to the distals, and then the proximal and the distal screws are put, and then unclose. This is the preoperative X-rays, distals comminuted fractures, and these are the postoperative X-rays. And the steps for
Field incisions of 3 centimeters given over patellar tendons, and then patellar tendons has been splitted, and 3 points are made with the curved diamond holes. Introduction of guide wires into the medullary cavities, and then proximal after medullary canals being rims with the anterior reamers, and the insertion of nail with this is the preoperative X-ray. Fractures both bones, the transverse fractures, and these are the post-operative X-rays. And we used ankle foot score, which consisting of 100 points. Pain, which consists of 40 points. Function, 50 points, which consists of activity limitation, support requirement, consists of 10 points. Maximum walking distance blocks is 5. Variables for the clinical radiological. Excellent is from 90 to 100, good is 80 to 89, fear is 70 to 79, poor is results. For midpoints, intermittent nailings, the mean age is 40 years. Mode of injury, RTA is common for both. Pattern of fracture in case comminuted fractures, MIPO is done, and transverse fractures, intermediate nailing is done. And the mean duration of surgery in case of MIPO is 79.9 minutes, and in case of nailing is 69.5 minutes. And the time of unions for MIPO, it was the mean time of union is 20.4 weeks, and in intermediate nailing is 18.9 weeks. Partial weight bearings mean is 5.8 weeks, and in case of nailing is 5 weeks. Full weight bearings, the mean full weight bearing in case of MIPO is 17.8 weeks, and in nailing is 17 weeks. So the outcome variables in MIPO it is 90% excellent, and nailing is 93.3, and MIPO 10% are good, and nailing is 6.7%. Discussion: Vestibular fracture are common consequence of the RTA, and its management still continue to be a problems. In present study, the patients were in the range of 90 to 50 years, with the mean age being 40 years. Similar results were observed by Douglas et al. In the study concluded in Assam, and most common cause of fractures were RTA, followed by sports, especially footballs, and present studies in correlate with Ram et al. The average durations of surgery in interlocking groups was 69.5, and plating was 79.9 minutes, which was comparable to the study done with Yu et al. And Yang Li et al. And the mean time of union in present study was 18.9 weeks for nailing and 20.4 weeks for MIPO. Similar study were conducted by Eknath D. Pawari et al. Average time of union was 17.43 weeks interlockings compared to 21.40 in platings, which is almost similar to the present study. Various studies done by Caspers vary similar results. Conclusion: based on our study, we concluded that both have viable option for the management of distal tibia, which each having its merits and demerits. Plus, has that nailing has the advantage of short weight bearings, decreased wound problems, early unions, decreased implant-related problems, and overall morbidities. Thank you, sir.
I congratulate you, Dr. Anil. You are almost on time. I will request Dr. BP Sharma to please start with asking a few questions.
After going through this paper, what you want to suggest when you use nail or when you use the plate in such a distal burst fracture?
Can you stop sharing your screen? Yeah.
So it depends on the pattern of the fracture, sir. If there is a comminuted fractures, we go for MIPO, and if there is transverse fractures, we usually go for nailing, sir.
Okay.
By saying this, you have totally refuted the whole aim of the study. If you are comparing apples with oranges, then the whole study is gone. You have to compare the two methods of treatment for similar type of fractures. If you are already biased, you are saying I will do this for comminuted fractures and this for simple fractures, then there is no point in doing this study. Dr. Sumit sir, your comments.
Yeah. So you have rightly pointed out, Dr. Harmesh. The thing is that you've presented it well with the X-rays and intra photographs. All that is good. But as far if you give this for a publication in any scientific journal, it will get rejected for the simple fact is that your study design, you said, is a RCT. First of all, it cannot be a trial. It cannot be a randomized controlled trial. Trials are done for pharmacological drugs, etc. And you need to, so this is a randomized control study if that way, but it is not a randomized control study because number one, the two groups are not equal or similar, right? So it is just a comparative study, right? And for any randomized control study, for your information, you need to have a CTRI registration. So you have to get registered. That is the ICMR requisition is that all clinical trials have to be registered, right? So this is not a randomized controlled study, and you are comparing oranges and apples, as rightly pointed out. So the outcomes are obviously going to be different, right? So that way the study design is not good, right? So it's not comparable. Yeah.
And personally, I feel more important than the fracture pattern. It is the local soft tissues which will dictate your treatment. In lower end of tibia, the most important thing is the soft tissue more than the fractures. So if soft tissue is not allowing you to do MIPO, whatever the kind of fracture it may be, you should never attempt at doing anything, kind of plating thing. So anyhow, Dr. Professor Sandeep, sir, please, your comment.
Yeah, thank you, sir. I just wanted to highlight few points. Rightly said, such studies have to be randomized. There is no confusion. Otherwise, you are biased from the start. One or two more things which I would like to highlight here is that you said that you only check the radiological union. In distal tibia, it is not only the radiological union, it is the alignment. Now you should have added the alignment part, because definitely fracture will unite. Either you do a nail or a plate. The important thing is whether it has united properly anatomically or not. So just by saying it united, because yes, the nailing is a good technique, but the papers, earlier papers have suggested that the malunion chances are higher in nailing as compared to plating. One. Second, how many screws did you use in the distal fragment? Because there are studies for that also. If you are using 2 screws in the distal fragment, the chances of malunion are high. So it is recommended that whenever you are doing a distal tibial fractures, usually you add on 3 distal screws. So did you see on that? Did you check on that? Did you write anything about that?
Yes, sir. Actually, I was using 2 distal screws, sir.
So again,
so malalignment was there, sir.
If is 2 distal, it is recommended that you use 3 screws rather than 2 screws. Okay, so the randomization is wrong. The concept of where you want to put a plate or a screw is again wrong. Then for how many days did you wait before jumping onto the surgery? Was it the same? Did you wait for more in the plating? Was there any criteria to decide that? So all these things needs to be taken care of. Whenever you are designing a study, then you have to compare apple with apple and oranges with orange. You cannot compare apples with oranges. Okay, so these 3-4 things are very important. So whenever you're doing any other study, then you should keep all these things in mind.
Dr. Chandip, I think for paucity of time, we can go to the next speaker now.
Yeah, we will go to the next speaker. Dr. Anup is our next speaker. His topic is functional outcome in a series of 50 supracondylar fracture humerus managed with lateral versus cross percutaneous spinning. Dr. Anup?
Yes, sir.
Can you kindly share your screen?
Sharing, sir. Is the screen visible, sir?
I can't see Dr. Anup.
I'm sharing my screen, sir.
Dr. Anil, before you go, mute yourself.
Is my screen visible now, sir?
Dr. Anup, I can't see. If anybody else can see, please mention. Otherwise, we will take that nobody can see.
No, we can't see it.
Shall we take the next person, Dr. Anup, till you're sorting this out?
Yes.
Right, sir.
Dr. Satyendra. Dr. Satyendra, are you there?
Yes, sir.
Kindly share your screen. Dr. Satyendra's topic is comparison of local injection of autologous PRP versus corticosteroids in management of plantar fasciitis. So PRP versus corticosteroids in the management of plantar fasciitis.
May I request Dr. Manish to
Hello,
mute others?
Yeah, Dr. Satyendra, we can see your screen. Please
Yes,
make it on a slideshow and please start. Better go down and make it on a slideshow.
Slideshow. 1 second. Good evening, respected sirs. Hello. Today my topic is about comparison of local injection of autologous platelet-rich plasma versus corticosteroids in management of plantar fasciitis. As we know, plantar fasciitis is a degenerative tissue condition that occurs near the site of origin of plantar fascia at the medial tuberosity of calcaneum. It is characterized by gradual onset of sharp pain along the medial aspect of the heel that is worse with the first steps taken in the morning or at the beginning of an activity and lessens as the person warms up. The common pathological features: increased vascularity, excess of ground substance tissues, and focal areas of fibroblast proliferation and damaged collagen fibers. The available routine treatment for plantar fasciitis or plantar fascia stretching exercises, strapping, NSAIDs, arch supports, and heel pads. Corticosteroid injections are often reserved for resistant plantar fasciitis after failure of conservative non-invasive interventions because of their anti-inflammatory effect. Recently, platelet-rich plasma, a blood derivative with a higher number of platelets than those found in the peripheral blood, has been used as a therapeutic alternative for obtaining relief and resolution of symptoms of plantar fascia fasciitis. Being a concentrate of platelets that are a source of autologous growth factors such as insulin like growth factor 1, transforming growth factor beta, vascular endothelial growth factor, platelet-derived growth factor, and fibroblast growth factor, helps in cellular migration, synthesis of collagen and angiogenesis, and then helps in ligament healing. Lacunae in existing knowledge: although a variety of treatment modalities exist, the results of treatment are inconsistent and there is no professional consensus with regards to the existing forms of treatment. Recently, local injections of platelet-rich plasma used in plantar fasciitis have been showing very encouraging results. However, there is paucity of Indian literature comparing the efficacy between local injection of autologous PRP and corticosteroids in treating plantar fasciitis. Research question: is there any clinical improvement in patients undergoing platelet-rich plasma injection evaluated by VAS score, Visual Analog Score, and American Orthopedic Foot and Ankle Society score? Is local injection of PRP superior than local injection of corticosteroids in treating plantar fascia? And hypothesis: local injection of autologous PRP is more effective than the local injection of corticosteroids in treatment of plantar fasciitis. And there were studies before I've shown that the treatment PRP and corticosteroids were similar at the 6 months follow-up trial. And even studies like Monto have observed significant improvement in functional outcome of the PRP group compared to the corticosteroid group throughout a follow-up of 2 years using AOFS score in 40 patients. And Vadadpur et al. Have demonstrated superior results with PRP treatment over corticosteroids at the 6 months and follow-up using the visual analog score and modified roles and Maudsley in 32 patients. And Acosta Olive et al. Has
been shown improved functional outcome in both groups over a period of 16 weeks in 60 patients, but no significant difference was observed between the groups using VAS, AOFS, and foot and ankle disability index. To my aim is to compare the efficacy between the local injection of autologous PRP and corticosteroids in treatment of plantar fasciitis. And here the study design was prospective randomized control trial, and the duration of study was till from October 2018 till March 2019, and sample size was 70 cases, 35 in each groups. And they were in criteria for selection of the patients. In the inclusion criteria, patients diagnosed with plantar fasciitis, failure of conservative treatment for at least 3 months, and patient age between the 20 to 60 years. And exclusion criteria, and any previous local injection treatment for heel pain, any history of surgery for heel pain, associated pathology involved the foot and ankle, and patients with systemic disorders like uncontrolled diabetes mellitus, rheumatoid arthritis, hematological disease, or gout, any local skin pathology, any trauma to the foot and ankle. And methodology, patient diagnosed with plantar fasciitis who satisfied the inclusion and exclusion criteria, we divided into 2 groups based upon randomization, random table. In patients of first group, 3 ml injection of autologous PRP will be given locally into the heel intrafacially from medial aspect, while in the second group, 1 ml of local injection of corticosteroid, that is injection depomedrol 40 mg, along with 2 ml lignocaine will be given after getting informed consent and routine investigation done, following all in aseptic precautions. From patients of group 1, 20 cc of venous blood collected into 4 vacuum of each of 5 cc each, containing acid citrate dextrose, and they will be subjected to differential centrifugation. And first spin 1300 rotations per minute for 10 minutes, and then blood in all 4 vacuum will have separated into 3 layers. The bottom layer comprising of RBCs, mid layer of buffy coat, which is containing mainly leukocytes and platelets, and the top layer of plasma with suspended platelets. The buffy coat and the top layer collected in 2 test tubes of 10 cc each will be subjected for second spin. And in the second spin, we will be going for 3500 rotations per minute for 10 minutes. Now the 1.5 cc of platelet plasma at the bottom of each test tubes will be collected and 3 ml injected into patient's heel at maximum point of tenderness in aseptic ways. So outcome, the patients were followed up at the interval of 15 days, 1 month, 3 months, and 6 months. Assessment were done using the 2 scores, Visual Analog Score and American Orthopedics of Foot and Ankle Society score. The comparison was done between these patients with bilateral plantar fasciitis. Each patient received local injection of autologous PRP in one heel and had corticosteroids in the other heel. And the graph showed graph of VAS score after injection of the platelet-rich plasma and corticosteroid. In one foot, the patient received a PRP, and another foot the patient received corticosteroids. And AOS scoring graphs. And in this graph, we can see that there was no improvement in pain between autologous PRP and corticosteroid study subjects in initial period up to 15 days, whereas after 1 month, 3 months, and 6 months duration, it is seen that autologous PRP injected study subjects showed significant relief in pain compared to local injection of corticosteroids. We conclude that PRP was more effective in reducing pain in patients with plantar fasciitis compared to corticosteroids, with the relief coming after first 30 days of injection. A longer period of follow-up is necessary to evaluate whether the beneficial effects of autologous PRP are sustained over a period of time. The limitations of our study were due to the small sample size of a study, and only 6 months of follow-up was done for the patients. Further studies on larger populations and longer follow-up periods are recommended to truly assess the results of local injection of autologous PRP in management of plantar fasciitis. Thank you. Yes.
Thank you, Dr. Satyendra.
Stop sharing your screen.
Yes, sir. Yes, sir.
So how did you prepare your PRP? There are so many various ways in which you can prepare your PRP. And how did you conclude that your PRP is good enough?
Sir, we collected a blood of 20 ml of blood, sir, from each patient. And then we divided it into 4 vacuum tuners containing acid citrate. And then we subjected it for differential centrifugation. We have gone through a number of experiments, sir, and among them we found in the trial which I have been shown it in the PPT was much more showing advantages.
Send your sample for
Yes, a pathologist.
What was the platelet number in your sample, finally sample,
Sir,
which you injected, and how much was the volume that you injected?
Sir, it was more than 4 times more than the normal platelet count, sir, in the peripheral blood film.
Okay, so you have really kind of hypothesized that it is better and proved also.
Yes, sir.
But were there any complications, any side effects, or do you foresee some side effects of PRP, or everything is good about it?
Sir, during the initial time, patient were complaining of pain, but I found it in both injection PRP and even corticosteroids, and I used only paracetamol.
Who prepared the PRP? The pathology department, or you yourself prepared it?
Sir, I myself prepared it, sir, under supervision of pathologist.
So pathologist came into your OPD, or you went to the pathology department?
I went to the pathology department, sir.
So the problem is, why I am asking these questions. The problem is, you draw a blood, you go to the pathology department, you get a PRP prepared, you come back to your OPD, and then you inject. So all these transport of blood from here to there increases the chances of infection. So the recommendation is, it has to be in-house, in the OPD or OT, wherever you are doing such procedures. The machine has to be there only. You can't take your blood and roam around in different departments. It will increase the chances of infection. It is proven in the literature. That's why I asked you this question.
Yes,
Dr. BP Sharma, sir, please.
How many times the PRP or steroid has been injected, whether it's a single time or a minimum some multiple dose?
Sir, it is only a single time, sir. We selected a patient with bilateral plantar fasciitis. In one foot, one heel, we gave injection corticosteroids, and in another foot, we gave PRP. Only one time, sir.
Pain subside out with the single injection only?
Sir, till the initial 15 days, we didn't find any findings, sir. But after that, eventually, we found somewhat PRP injected patients found much more beneficial, where they were much more beneficial than corticosteroids.
And they are totally improved with a single injection?
Yes, sir.
Okay.
We have 2 more speakers. Can I proceed with the next speaker, chairman person?
Yes, we can proceed.
Professor Sumit, sir, should I proceed?
Yeah, I just wanted to ask. So when your study is designed well, again, it's not a randomized controlled trial; it's a study, right? And so this randomization that you have done is an open labeled, right? It's not a blinded, neither single nor double, open labeled.
Yes, sir.
Right? And so the outcomes, the score which you measured was at the intervals of how much? Just can you just repeat?
At 15 days, 3 months, and 6 months. At the day of injection, sir, and later on 15 days, and then on 3 months, and then on 6 months.
So the VAS score at 15 days, was there a difference?
They were telling that somewhat. I mean, not much findings I found, sir. I mean, they were telling the same
what
thing.
What happens is that usually there's an increase because you cannot give NSAIDs, right?
Yes, sir. No, sir. I gave only injection tablet PCM.
All these things should have been highlighted because what Dr. Harmesh also pointed out, that the platelet less than 1.3 lakhs should be excluded. So when you put in such a nice study and written all those criteria, should have been highlighted there, right? And NSAIDs you did not use.
No, sir. I used only tablet PCM.
Yeah, so usually you give other therapeutic things like ice packs or something because there is increased pain after the injection.
Yes, sir.
Right. And very rightly said. So because we have been doing it for so many years now inside our own operation theater, so you don't have to. If you're going across multiple departments, the chance of infection is going to be high. So you need to look into that aspect. Yeah. Otherwise, yeah, well done. Yeah. Thank you.
Thank you.
The next speaker is Dr. Anup. Dr. Anup, are you ready to share your screen now?
Yes, sir. I'll share my screen again. Is my screen visible now, sir?
It is visible, Dr. Anup. Please start.
Yes, sir. Sir, we have done a study to compare the functional outcome in a series of 50 cases of supracondylar fracture who were managed either with lateral pinning that can be parallel or divergent, and cross pinning technique. As we know, sir, supracondylar fracture are one of the most common elbow injuries in children, and it accounts for quite a big chunk of traumatic injury in pediatric patients that present to us. And they are associated with complications like malunion or neurovascular complications at presentation also, and even as a complication of doing a surgery which is done with a poor technique. So in this study, we've used Flynn's criteria, and we've compared functional outcome at 4 weeks, 6 weeks, 8 weeks, and then at 6 months post procedure. This study was conducted in Command Hospital, Lucknow, in a military tertiary care military hospital, where we have seen 50 children. These were primarily under the age of 8 years who had specifically type 3 supracondylar fractures, the completely displaced types, which were managed either with the cross pinning or the lateral pinning fixation based on the surgeon's preference. And all these patients were operated under general anesthesia. On analyzing the retrospectively analyzing all the pre and post radiographs and the function of the patient, we found 10 patients who were managed with cross pinning technique, and around 40 who were managed with just lateral pinning, either divergent or parallel. So just representative X-rays of the patients of who are managed in who are managed with either crossed or the lateral pinning technique. Here we have studied the loss of range of motion of the elbow, or any malunion, valgus malalignment post-operatively, which resulting in poor functional outcome in the patient. And we followed the patients for 6 months. Probably a longer follow-up is required to see whether the physes were damaged in the surgery or not. However, in this 6 months follow-up, we found that one patient had ulnar nerve injury, which recovered spontaneously in due course of time after the medial pin was removed. This was in the cross pinning technique, and there were no neurological complications in patients who were managed with lateral pinning technique. This is like a standard which is given in the books. But what we wanted to highlight by doing this study was whether a properly done cross pinning technique, which when we take care of the ulnar nerve, still because the experience of the surgeon is generally like what we are also taught in presently is to practice lateral pinning technique only. and try and avoid cross pinning if the stability is achieved only through the lateral pins. But in this also, what we found was there was the functional outcome in cross pinning and lateral pinning technique was same, and the rate of complications also is same, and is not statistically significant between the groups, and all the patients achieved good functional outcome at the end of 6 months. Right, sir. I thank you, sir. I'll rest.
Thank you, Dr. Anup. Can you stop sharing your screen, please?
Right, sir.
Professor Sumit, can you please take over?
Yeah, so thank you. So that's towards the end of the our session, we are getting more and more studies, research studies of a proper nature. So was this a prospective study or a retrospective study?
Sir, it was a retrospective study, as in the surgery was done when before the study was conceptualized. However, the follow-up was a prospective in nature, sir.
Yeah,
when we formulated what to look for in the patients.
So because of your unequal sample size, that's what I was thinking. Otherwise, what was the reason that why you had unequal sample size? So if you had a maybe the strength of the study would have been better if the sample size would have been equal and it would have been a prospective study, right? So otherwise, these are whatever you've presented are well-known facts, but again, we are research is going on. So if you want to really publish such things, then you have to do prospective, proper randomized study. Yeah. Otherwise, there's no especially new message, but yeah, you presented well. Yeah.
Thank you, sir.
Can we move ahead, Dr. BP Sharma?
Yes,
Dr.
you
Sandeep
can.
Kumar?
You can move ahead.
So I want to ask one thing. You never mentioned whether it was an open reduction or a closed reduction. Because
Sir, yes, sir. I missed that out. Sir, all the open reductions were excluded in the study. Patients having compartment syndrome or preoperative neurological injuries were not included in the study. In this, we have type 3 supracondylar fracture without any preoperative complication, and compared after close reduction and fixation, the complication and functional outcome in only that subset of the patients. Sir.
Only the close reductions were taken.
Yes, sir.
Thank you.
So the next speaker is Dr. Madhan. Dr. Madhan, are you there?
Yes, sir.
Please share your screen and
very good evening. I'm Dr. Madan Jayaraman. I'm a PhD scholar under Stem Cells and Regenerative Medicine in Sharda University. I'm just presenting my pre-PhD work on my PhD topic, cellular therapy in osteoarthritis knee. So basically, what is osteoarthritis? It is the interplay between a rate of cartilage degeneration versus rate of cartilage repair. The main mechanism for the degeneration is the production of IL-1, interleukin-1 pro-inflammatory molecules. So what we are going to aim at, we are aiming in to achieve interleukin-1 receptor antagonist. So here we are going for orthobiological therapy, which is called cellular therapy. So basically, it is defined as the transplantation of human cells to replace or repair the damaged tissue or cells. A forum called International Society for Cellular Therapy has formulated a criteria. Whatever cellular components we are going to transplant, it should be able to form cellular components of trilineage, that is osteogenesis, adipogenesis, and chondrogenesis. When these cells cultured or co-cultured in a petri dish or lab media, it should be able to show fibroblastic morphology. And at last, there should be at least 4 immunohistochemical markers should be positive. That is cluster differentiation 13, 73, 90, and 105. So what are the basis of orthobiologics? So there are 3 components. One is matrix materials, second one is growth factors, and third one is stem cells. All these 3 should be in a coordinated way to have a regenerative homeostasis. This matrix materials forms the ground substance for the stem cells to anchor, and growth factors will enhance the growth of stem cells, and the stem cells as such will give the differentiated final product, either it is cartilage or bone or fat tissue. So what is ideal cellular therapy? Ideal cellular therapy is nothing but it should be an autologous source. It should be taken from the person and it should be transplanted back to the same person. And it should be transplanted in the same surgical session. And there is some terms called minimally manipulative and more than minimally manipulative. So we have to avoid totally manipulation. Chemical manipulation has to be avoided. And cellular therapy will provide stromal cells and matrix materials. And we should not use any artificial scaffolds to grow the stem cells. And if needed, we can culture and we can expand the cells and we can use for the treatment options. So there are a lot of sources of MSCs, bone marrow, amniotic fluid graft, adipose tissue, placental stem cells, umbilical cord, endometrium, dental tissue, and synovial fluid stem cells. So in my PhD, I have taken bone marrow stem cells and adipose tissue stem cells. So basically, or as an orthopedician, we are much more worried about, not worried, it's concerned about mesenchymal stromal cells or stem cells. This mesenchymal stem cells have self-renewing capacity and multipotent differentiation capacity. So it will differentiate it into ectodermal components, mesodermal components, and endodermal components. So we are targeting more of cartilage cell, that is chondrocyte. Chondrocyte is basically, it has intrinsic limited regenerative potential. So first thing is I'm going to talk on bone marrow stem cells. So bone marrow stem cells, such when we try to aspirate from iliac crest, it should be subjected for double centrifugation, that is differential centrifugation. When we take bone marrow aspirate, we cannot concentrate the stem cell part. So we are sending this bone marrow aspirate for a centrifugation, and where we will get a BMAC, that is called bone marrow aspirate concentrate. In between the plasma layer and the RBC layer, there will be a buffy coat layer where bone marrow aspirate concentrate will be there. If we take a drop and put under microscope, we can see stromal cells. The second thing, what I'm going to use is adipose tissue stem cells. So adipose tissue stem cells can be derived from lipoaspirate from the lower abdomen or medial part of thigh or gluteal fold. So once lipoaspirate has been taken out, there are certain ways to prepare stromal vascular fraction. But there are some derivatives of adipose tissue stem cells. One is macrofat, microfat. This is nanofat, microvascular fragments, stromal vascular fraction, adipose stem cells, secretomes, and exosomes. These adipose stem cells can be converted into adipose stem cell sheets and adipose stem cell spheroids. But these adipose stem cells can be loaded into a scaffold for the places where it is very much needed. The concentration is needed. So there we can load with an carrier molecule, that is the scaffold. But ideally, cellular therapy, we are supposed not to use any artificial scaffold. But natural scaffold, SPRP gel can act as a natural scaffold where you can load the stem cells. So how I'm going to prepare stromal vascular fraction? There are 2 methods. One is enzymatic method. Second one is mechanical method. Enzymatic method is not approved in India. So I'm following this mechanical method. In enzymatic method, once lipoaspirate is taken, we have to introduce collagenase enzyme 1 or 3 and subject for centrifugation of 1200 RPM for 10 to 15 minutes. The final product, what we get in the pellet is this bottom portion will be the SBF. That is stromal vascular fraction. Mechanical method, same. First, we have to aspirate the lipoaspiration, then lipocondensation. Once lipocondensation is done, we have to go for Luer lock injectors. That is this pink color thing which is connected between the 2 syringes is called Luer lock injector, where we will convert macrofat into a microfat. So there will be a crisscross process. So we have to pass minimum 20 times between both the syringes. So it will convert 4,000 micron adipocyte into 100 microns. Then this is called microfat. This microfat is subjected for 1200 RPM to form a nanofat. Finally, that nanofat will be subjected for another 1200 RPM for 6 minutes, will form a stromal vascular fraction at the bottom of the tube. Next is placental derived stem cells. Placenta is an immunoprivileged organ. It is completely packed with stem cells, various different types of stem cells. One is amniotic epithelial stem cells, mesenchymal stromal cells, chorionic stem cells, decidual stem cells, and complete placenta itself. We can mince the placenta and we can use it as a stem cell organ. So how stem cells will act? It has anti-catabolic effect, anabolic effect, and anti-inflammatory effect. Mainly, we are concerned about induction of interleukin-1 receptor antagonist, that is IL-1RA, and the other anti-inflammatory molecules. This will help in suppressing the pain, and it will help in regenerating the chondrocyte. That chondrocyte regeneration will take a longer time than expected. So I'll come up with the next slide. Then BMAC in ONE. There are various studies that has been conducted in past 5 to 10 years that BMAC, everyone has done work, but they have not proved whether cartilage is grown or not. So the second one is SVF, the same. SVF also states that whether there is increase in cartilage thickness after the injection in follow-up period or not has not been proven. So I have done a meta-analysis recently in 2020 August. So I have compared both the sources, either the bone marrow stem cells and adipose tissue stem cells, how it is helping in growth of cartilage. So adipose derived mesenchymal stem cells have more mesenchymal stem cells than BMAC, bone marrow stem cells. But cartilage forming capacity is more with bone marrow stem cells than adipose derived stem cells. The one great advantage in adipose derived stem cells is growth factors and cytokines are more in adipose derived stem cells, which will help the cartilage to grow more. Thereby it has the capacity for cartilage growth potential. So there are a few ethical concerns in using the cellular therapy as such. So FDA has given some definition called minimal manipulation of cells. So minimally, while we manipulate the cells, we should not alter the biological property of the cell of interest to be regenerated. So there are few sections, 351 and 361, where 351 will tell about the regulation of biological products and 361 will tell about the non-subjective post-marketing requirements. So this 361 states that stem cells, not stem cells, cellular therapy, any cellular therapy has to be minimally manipulated. It should not be more than minimally manipulated. Like we should not add any chemicals. If we add any chemicals, that will form a drug. So it is prohibited. So minimal manipulated can be done, and homologous use. It has to be applied only for homologous usage, and we should not add any articles except water, sterilizing agent or storing agent. And whatever cell we are giving in the site of action, it should not have any systemic effect or it should not act any metabolic effect on the particular area. So the next advanced thing in the stem cells is exosomes, that is mesenchymal stem cell derived exosomes. Exosomes are nothing but it is present all over the body, either it is cell or fluid, any body fluid. If you take, there will be exosome. Exosomes, in these exosomes, the molecules, all these molecules will have a biological action. These are the molecules like tetraspanin, ceramides, phosphatidylserine, all cholesterol, sphingomyelin, all are exosomes. These exosomes have biological property. Along with these exosomes, there will be small mRNA, messenger RNA and small RNA. All these form to have a final regenerative homeostasis. So while comparing exosomes and stem cells or cellular therapy, exosomes stands higher in therapeutic potential. It has all the properties of trophicity, anti-inflammatory, immunomodulatory, and therapeutic effects. Hence, it supports neoangiogenesis and cellular proliferation. But the composition and uncertain functioning has to be explored. So this is my pre-PhD workup, which I'm going to compare both BMAC and adipose derived stem cells in cartilage growth by taking pre and post MR cartiogram, and I'll see their functional outcome. So hence I conclude that I hope that cellular therapy has cytoinductive, conductive, and integrative properties in treating early grades of osteoarthritis. But the question here is whether cartilage is growing or not. So scope for future research is based on cellular therapy, whatever we are using, the dose has to be standardized. Either how many number of cells has to be used has to be standardized, and frequency of the injection. Then universal, the main concern is universal protocol and preparation. There is no standard protocol. How many RPM has to be used, how many time minutes has to be used. This has to be standardized. Then once standardized, how much amount of growth factors or the components, cellular components we are giving in the site of action. Then usage of autologous or allogenic formulation. The main thing is radiological documentation on cartilage growth has to be proved. Then finally, RCTs has to be conducted to prove its efficacy. Thank you.
Very extensive presentation, and maybe the next research, maybe another 1 or 2 years down the line, we'll have something regarding this, something new on the horizon.
Sure,
I'm sorry, but this is slightly out of my league. So, Professor Sumit, Professor Sharma, and Dr. Harmesh, if you would like to take over the session.
This is the first paper which is actually in spirit with the theme of this conference, futuristic orthopedics. So that way it's very exciting, and I'm sure stem cells have a lot of room to play in all the medical field, be it orthopedics or anywhere. So although I don't have much knowledge into this, but I'm sure you people like you are going to come up with very good therapies. Dr. Sumit, sir.
Yeah, very well presented, very nice slides and good presentation. So now what I understand is that you are going to do it only with the adipose cells, right?
No, sir. Both. I am going to compare bone marrow stem cells versus adipose tissue stem cells, sir.
Okay. So when you're taking the adipose
yes, sir.
cell, okay, then one is lipoconcentration, you said.
Lipocondensation, sir.
Condensation. Okay, I
Yes,
didn't.
sir.
So how the lipocondensation? What is the process? We just keep it there.
Sir, I have to collect via that tulip device. There are some devices to collect lipoaspirate, sir. So I'm planning to take the help of plastic surgeon to aspirate the adipose tissue from that fat pad. Then I will process it for lipocondensation is nothing but I have to first initially centrifuge it, sir. Once I centrifuge, that RBCs, whatever is sticking onto that adipose tissue will come out, sir. Then I will pass under Luer lock syringes, injectors. Then I will have one more centrifugation to have a final product, sir.
So
It's a bit complex.
Like the bone marrow, you are taking out the buffy layer.
Yes, sir.
Right. So here you are just discarding the RBC and taking out the rest.
Sir, no, sir. The last column will have a bottom portion of pellet, SVF pellet. SVF is nothing but it has a
SVF only from the
yes, sir. It is a variety of cells where it has pre-adipocytes, adipocytes, pericytes, endothelial precursor. Everything will be there. So it is a collection of cells, sir.
Right. So you'll be able to distinguish between the SVC and the rest.
Yes, sir. We can distinguish, sir. Yes, sir. Yes, sir.
Okay. Good. Share your results.
Yes, sir. I'll present when I finish my study. I'll definitely present in DOACON.
So what about the cord blood? Nowadays, it's a trend for last 10-15 years that every delivery, these few companies collect the kind of placental blood and whatever, and then they store it for 25 years. And then they say that it is very useful. There may be some tumors and some cancers where it may be needed. So what are your views on that? Is it really a worthwhile exercise, or it's more of a commercial gimmick?
Sir, to be frank, I have never seen any result on collected cord blood used for any of the cancers or anything. Maybe for hematological cancer, yes, sir, definitely they are using, but not for other cancers like bone cancer or any other abdominal malignancies. No, I have not used. I have not seen, sir. Till now, no results has also been published by any of the commercial companies who are collecting and storing it. But yes, definitely there is a role in hematopoietic cancers, sir, hematological cancers. Blood malignancies they are using, sir.
Any other paper left?
Chairman, sir, can I ask 1 or 2 questions?
Yeah, sir, please.
Thank you. Dr. Madhan, actually, this is an idea. This is not a paper.
Yes, sir. I have told already to
You
Secretary, sir.
started your studies. Okay.
Sir, I have started, but they all are in preliminary stages. Four cases I have done.
Idea is wonderful. Idea is wonderful. You have elaborated the way you have to prepare the stem cells and the various other cells which can be used. Okay, it's a very challenging idea. But apart from MRI cartogram, is there any other way which you are using in your study to assess the development of the chondrocyte or a cartilage? Because MRI cartogram is there for a very long time, and we are getting it done. We are using it also, but how authenticated it is?
The second procedure we are planning for is second look arthroscopy, sir. Once we do a scopy and we'll take a biopsy, we have to see once again either the cartilage chondrocyte is growing or not. Has it been grown or not? We are going to do, sir. But it will be done only after the second year, sir.
That is what my next question was. Because whenever you are doing such studies, you usually do a histological studies.
Yes, sir.
Do the experimental animal studies. Okay.
Yes, sir.
When you are using 3 or 4 or 5 types of cells, then you make control groups, and there has to be a control group. Then on an animal like a rabbit or some other animal, you have to use it. You have to sacrifice that. You have to do a histological study, and then only you can go for such studies.
Sir, actually, one of my colleague is doing on basic sciences animal studies, sir. So based on that results, we are going to extrapolate for human trials, sir.
Because I am saying this because when you are talking about the cartilage, the quantity of the cartilage, the quality of the cartilage regrowth, then it cannot be assessed simply by a cartogram or even by an arthroscope. Because it's at the cellular level.
Yes, sir. Yes, sir. Yes, sir.
It's not an anatomical morphology.
Fine,
right?
sir. I'll include this point as well, sir.
So I think it is better whenever we do such studies. The stem cell research has been there for the last 15 years now.
Yes, sir. Yes, sir.
We have used this blood and this, I think way back in 2005, the first paper was there on osteoarthritis. But then I think it's a wonderful idea, and we will look forward for your study that what it comes out.
Sure,
Okay?
sir. Sure, sir.
Thank you.
Thank you, sir.
There is one topic which is left, Dr. Himanshu. He's saying that he's spoken to Ravi. I've told him to speak to Harmesh as well. If the chairpersons allow, I will ask him to speak, because I am not the one deciding who speaks and who doesn't speak. I'm just coordinating.
What is the topic? If the topic is interesting, we can hear him.
The topic is, where did the topic go? Tenosynovitis, tubercular tenosynovitis of the hand, a rare presentation.
Let it be 5 minutes, I think, if Dr. Sumit is okay with it. And Dr.
Actually, he has actually applied, he has put his paper did not come in the list. So he had requested that I've already applied. So I think we should give him a chance for 5 minutes.
Okay, fine. Good.
No, am I audible, sir?
Yeah, yeah.
Sir, I just talked. They are saying that I will the tubercular tenosynovitis poster will be presented tomorrow. Sir, I also have a paper on chronic cordyceps rupture management chariot technique. So if you'll allow, I will present the paper on this platform.
No, you decide one. If you are putting that in your paper, you should not repeat. I think Harmesh will take the call. What do you say, Dr. Harmesh?
Sir, I think let's hear him out. Hardly it matters, 5 minutes. Let's hear him out. Yeah.
Okay, sir. And then I'll present my paper, sir, on chronic cordyceps rupture, sir.
Dr. Harmesh, please take that call.
I think it's okay. 5 minutes we can hear him out. If everybody is okay. I mean,
Should I start, sir?
Make it full screen, na? Your paper, you make it full screen.
Rotate your phone. Rotate your phone.
Okay, sir.
I think you're doing for the mobile. Okay.
Is it fine, sir?
Yep.
It's fine.
Good evening, respected teachers. Today I'll be presenting my paper on the novel chariot technique for chronic cordyceps rupture management, a case report. Cordyceps tendon ruptures are a very uncommon presentation. Its incidence has been reported to be 1.37 per lakh every year. The diagnosis can be confirmed by ultrasonography or magnetic resonance imaging. The early surgical repair has best clinical outcomes. Missed injuries and neglected trauma leads to chronic quadriceps tendon rupture and poor clinical management outcomes. I'm presenting the case of a 48-year-old male patient who had an 8-month-old history of road traffic accident, who presented to us in our OPD with chief complaints of inability to walk independently without putting hand over his left distal thigh, and inability to stand over the affected leg. That is, he was unable to stand on one leg. On examination, we found out that he was unable to bear weight over his left lower limb with knee fully extended. The straight leg raising was not possible on the left side on lying down position. Although passive flexion and extension of the left knee was possible, there was significant wasting of the left distal thigh and calf muscles, and a gap was palpable anteriorly just above the superior edge of the patella in the continuity of the quadriceps muscle. The diagnosis was confirmed. First of all, an X-ray was done, which showed no bony abnormality. Ultrasound was done, which showed a discontinuity in the quadriceps tendon just above the superior wall of patella, which was confirmed on the MRI. And a diagnosis of chronic quadriceps rupture was made. We then operated it. The operative technique included a supine position and an anterior midline incision from the distal 1/3 of the left thigh to 3 centimeters below the distal wall of patella. The debridement of the fibrous intervening tissue along with the edges of quadriceps tendon was done, and the superior wall of patella was also roughened and freshened. Then the mobilization of the proximal ruptured portion of the quadriceps tendon was done to achieve better excursion of the tendon, and 3 Krakow web stitches were taken with the help of number 5 non-absorbable ethibond sutures from lateral side through the vastus lateralis muscle, and from the middle from rectus femoris and vastus intermedius muscle, and from the medial side through the vastus medialis muscle. And they were then traversed through 3 drill holes made in the patella, lateral, middle, and medial, using a 2.5 mm drill bit along the whole length of the patella, and then respective sutures were tunneled through these holes to the distal wall of patella. So it, in a fully extended position, the sutures were tensioned and they formed a kind of a chariot at the distal end of patella, thus decreasing the gap that was present and the rupture that was ultimately sutured. These are the intraoperative photographs which showed a 6 centimeter gap in the quadriceps tendon. The figure on the left shows the intraoperative photograph in extension position, and the figure on the right shows the position in flexion position. And this was the technique, the chariot formation with ethibond, which shows us the 3 ethibond sutures in the quadriceps tendon proximally and through the patella, which was tied at the distal end of patella. This was the after full repair. This was what we achieved, and this was the final outcome, which was it showed a range of motion, active range of motion 0 to 120 degrees at knee after 1 year of the operation. This was the full active straight leg raising possible, and it was this much flexion was achieved at the end. Now discussion. Quadriceps tear classically occurs at a relative hypovascular zone of 1 to 2 centimeter above the proximal of patella. The advantages of this chariot suture technique includes it is very effective. There is no requirement of any synthetic graft, autograft, or allograft. There is no donor side morbidity, and it makes a strong construct, and it is cost-effective method. So my conclusion is chronic quadriceps rupture is a rare entity, and we have used a novel chariot suture technique with good outcomes. This technique has provided very promising results, probably due to high construct stability due to chariot formation. And this technique is cost effective and has no donor side morbidity and easy to learn and practice. Thank you.
Thank you for your presentation, Dr. Himanshu. This was only one case. Am I able to understand correctly?
Yes, sir.
Stop sharing your screen, Christian.
Yes, sir.
So, Dr. Harmesh, please take over.
So what I understand is you're saying it's kind of a direct repair in a chronic tear. So is
Yes,
it?
sir.
I don't think it is possible every time. Although you was lucky to do it, but I think VY plasty or some kind of a reinforcement has to be done most of the times. I'll request Dr. Sumit to throw some more light on this.
Yeah, I think so. It will depend upon because this is just a case report, what I understand. So, if it's a long chronic thing, then you may have to mobilize with the VY plus T.
Yes, sir.
So, regarding your this case, why have you used the term chariot? Because of the rains that they're.
Yes, sir. Yes, sir. Because of the rains, that a structure that is formed at the end of the procedure, it resembles that, so we call it a chariot.
It would have been good if you had shown diagrammatically exactly the holes that you made in the patella, and I didn't understand. You've taken 3 Krakow sutures, and that separately, one from the lateral vastus lateralis, one through the rectus and the vastus intermedius, and one through the vastus medialis. Is that what I understand?
Yes, sir. Yes,
3
sir.
separate.
3 separate sutures and 3 tunnels were made in the patella.
So, what is the direction of the tunnel in the patella?
Sir, they were converging at the distal pole, sir.
No,
They
could
were.
you draw a diagram or something? Because 3 tunnels, how close they were, the cutout of those tunnels, and was it necessary to put in the tunnel through Delbit? A good number 5 ethibond can go through the bone also. So, what was the location of these tunnels? All these things when you are highlighting on this thing, because I was just doing a Google search, and apparently I've also done a publication in the Science Direct on this technique, right, which I have not gone through, but it should have been a little more explained diagrammatically.
Okay,
The tunnels, the position, the how far they were from the superior pole, right?
I understand, sir. Yes, sir.
Yeah, so that would have been clearer.
Okay, sir. And
I agree with Dr. Harmesh that maybe not in all cases where you are able to mobilize and approximate the distal end of the patella to the proximal pole of the distal end of the quadriceps tendon to the proximal pole in full extension. In those cases, probably you are trying to do.
Yes,
right?
sir.
Without a VY plasty. Yeah.
Yes,
Yeah,
sir.
thank you. Yeah.
Thank you.
Come to the end of our session. With that, I would like to thank the chairpersons. I'd like to thank Dr. Manish Dhawan for being there always to help in keeping decorum.
Thank you. Thank you. Thank you.
If there are other people left who are the presenters, I think all the presenters have left. Just a few of them are left.
Yeah, I think.
So my suggestion to them is please take all the advice given with a pinch of salt, because all of us have done these mistakes, have crossed these hurdles and reached where everybody has reached to give you those advices. That's my only suggestions.
Yeah, initially I thought that, this session will finish very early, but we have exceeded by 47 minutes. So 4 o'clock, I thought, very less speakers were there, but it made a difference,
And as Dr. Professor Sumit said that, towards the end, it became slightly more spicier academically.
Yeah. Yeah. So I thank everyone, and especially our panelists, Dr. Harmesh, Dr. Sumit, Dr. Chandeep, everyone, and Dr. BP Sharma. So really thank Dr. Professor Sandeep, who also had a good contribution. And I think anyway, Dr. Shashank Mishra, he is also there, I think. So I thank everyone from DOA who were part of this thing, and let us now basically look for tomorrow morning at time.
Yeah, and I think we need to thank Dr. Shamsul Huda and Ortho TV for doing a brilliant job.
Yeah, Shamsul is the pillar of.
Yeah, so
Shamsul
they have done a great job in putting up this show. And
Thank you, sir.
I would like to hear Dr. Shashank. He is joining us from Canada. Dr. Shashank, good morning.
Harmesh, I was just for keeping a low profile because I joined late.
So hope you enjoyed whatever bit you could.
Yes.
Yeah.
Thank you very much. That was though I could hear only last 3 or 4 presentations, but it was really good.
कुछ लोगों के साथ low और profile match नहीं करता शशांक.
So again, I thank Dr. Sumit, Dr. Professor Sandeep, and Dr. BP Sharma to really spare their precious time in listening to these PG papers. And thank you and good night, everybody. Yeah.
Thank you very much, sir.
Thank you so much.
Thank you, sir. Shall I stop live, sir?
Yeah, sure.
Yeah.